Hello, good evening. ريان اكتب القصة كتبتها؟ Hello, good evening everybody. Can you hear me? Good evening. Thank you for joining us today. Webinar on iron deficiency anemia in women's health and the impact on women's life. Sponsored by Pharma. Some points to for your notification. The webinar is live on MCI Middle East YouTube channel, and on demand you can review it again on MCI Middle East YouTube channel. Please, if you want to ask any question on the question and answer box, you can write down your question, and at the end of the session, we'll be asking the speakers. And if you favor some speaker to direct the question to, please write down the name of the speaker. Live will be, you can chat with the support group on WhatsApp during the event. Plus 971 56 99 44 287. And our webinar is CME accredited 2.5 points by Muhab. I'm Dr. Tagreed. I'll be the moderator of today's webinar. I'm consultant internal medicine in Latifa Hospital. And I would like now to introduce our first speaker, Dr. Salima Wani. She is the Acting Deputy Chief Medical Officer, Academic Affairs Department in Corniche Hospital in Abu Dhabi, and she'll be talking to us about hands-on experience on iron deficiency anemia management and the peripartum conditions. Welcome, Dr. Salima. تفضلي.
Thank you very much for inviting me for this webinar, which is very important in our day-to-day practice. And my talk is very committed to our experience as well on iron deficiency anemia in peripartum period. I just want to go through a couple of tests first before I want to say, because there is You can have patients in different scenarios. You can have a 35-year-old attending the clinic at 36 weeks pregnant, very mild symptoms, telling you, I feel tired. I have sometimes exertional dyspnea if I go upstairs. And if you check her vitals, she's absolutely stable, except her pulse may be a little bit higher or may not be. You checked her hemoglobin, it came back as 87, which is 8.7, or MCV you checked, it's 72. You can have another scenario, which is nowadays very common. You have patients with bariatric surgery, which can be quite young patient, 29 weeks gestation, complaining of palpitation and feeling tired. Hemoglobin you checked, it is 78, and you checked her MCV, which is normal, 84. And she then gives a history that she has raw NY gastric bypass. So these are the common scenarios which we see in clinical practice nowadays. So my objectives will be to give a brief introduction to the problem, a definition and epidemiology, some maternal and fetal risks, universal supplementation, diagnosis, management, and some conclusions. Anemia, as you know, is a public health problem globally, even though it's more common in the low-income countries, but it's common globally. The World Health Assembly, goal of World Health Assembly is to reduce the anemia in the reproductive age group by 2025 by 50%. Well, is it achievable? That we will see by 2025 what happens. More than 50 million women are anemic. And what does it lead to? It reduces the capacity to work and increase the healthcare cost. And that we know, if anybody is not able to work, it increases and they have frequent visits to the hospitals, it increases the healthcare costs. Not only so, it increases the poor birth outcomes like preterm birth, low birth weight, and perinatal and neonatal mortality. The risk of maternal mortality can be reduced by 25% for every gram of hemoglobin which is increased prior to pregnancy or during pregnancy. Although, as I said before, it's more common in the less developed countries, but it's still a significant problem in the developed world. What is the significance you can attach as a public health significance? It depends on the prevalence of the anemia in a particular country. It's of mild significance if the anemia is less than 20%. It's of moderate significance if it's between 20 and 40%, and severe if it is more than 40%. So what we all need to think of is successful reduction in the prevalence of anemia will lead to improvement in women's work productivity, improves the pregnancy outcomes for the mother as well as the infants, and increases the children's school performance. This is because of the anemia being, if it's common in the young age, it carries on in the childhood as well. So if we improve the anemia, what it results? It results in the benefit to the individual health and well-being, and also leads to the potential economic and community development, as I said before, about performance of the children in school. World over, about 1.62 billion people are suffering from anemia. Of this, 56 million, that's 1/3, is in the reproductive age. There is regional and global variations, and 40% of the pregnant women in developed world are anemic, which can go to up to 50% in the low middle income countries. And 2/3 of this population lives in Asia. I'll show you the map later on. And large proportion of these women who are anemic are iron deficient even without anemia. This is the world map of iron deficiency anemia in pregnant women. And this is the last one, which was published in 2016. The darker the color, the incidence of the prevalence of anemia in that particular area can be up to 70%. So variation between 6 to 70%. You can see like in India and Pakistan and all Southeast Asia is very, very high prevalence of anemia. Now, if we look into the Middle East, it's not less common. It's as high as 47% in the Egypt. And these are older studies, and these are from WHO website. And in UAE, it's almost 26%. So what's needed? We know that it can have serious adverse health consequences, not only to the mother, but as well to the child. So the effective management is needed to prevent, to reduce to improve the perinatal and maternal outcomes and reduce the need for the red cell transfusion, which my other colleague is going to talk about, is the patient blood management. Definition, if you want to use universal definition and easy definition, that's WHO definition, where you say hemoglobin less than 110. If you want to differentiate as per the CDC, you can have hemoglobin less than 11 in the first trimester and in the third trimester, but hemoglobin of 10.5 in the second trimester. The reason being I will speak later, which is about the hemodilutional effect, which is that there is increase in the total blood volume, but the blood plasma volume is increased much more than the red cell volume. So there is a relative hemodilution. Does it have a benefit? Yes, because the viscosity of the blood becomes less, so it becomes more thinner and improves the placental perfusion. In addition, we know there's a shift in the hemoglobin dissociation curve, which facilitates the oxygen delivery to the fetus. What are the iron requirements during pregnancy? Total iron requirements during pregnancy, about 1200 milligrams. Of this, 1/3 is required for fetus and placenta. More than 1/3 is required for hemoglobin mass, which is increased during pregnancy, and about 150 is lost by excretion. So this is important for the erythropoiesis. As we know, increase with the gestational age, erythropoiesis increases and returns to normal after 5 weeks of delivery. And this is what iron requirements are. The highest iron requirements are between second and third trimester. In the first trimester and in the postpartum period, the requirements are much lower, but second and third trimester is the most important period where the requirements go as high as 6 milligrams per day in comparison to about 1 milligram a day before pregnancy or in the first trimester. What we see as iron deficiency anemia is basically an end of the spectrum of a syndrome. So iron deficiency is a syndrome, which is a progressive process. It starts from iron depletion, which is stage 1, where there are only stores of the iron are deficient. It is followed by depletion of stores plus transport iron, which is iron deficient stage. And the third is iron deficiency anemia, which we check by doing the full blood count or CBC. In this, you find reduced stores, reduced transport, and as well the functional iron. So initially, we used to take about ferritin of less than 13 initially, but recently all over the world, the recommendation is you should be checking the serum ferritin, and the cutoff for serum ferritin should be less than 30 is anemia. And this is important because it is required for the growth of the fetus as well as for the erythropoiesis. Is there any women which are particularly at an increased risk of anemia? This is a huge group of patients who are particularly where the anemia during pregnancy can be very high risk patients. These are previously if they are anemic, if they are multiple pregnancy, consecutive pregnancy within less than a year of interval, vegetarians, teenage pregnancies, chronic blood loss, parasitic infections, and some chronic diseases like inflammatory bowel disease. As I said before, the symptoms are very, very non-specific unless the patient is very severely anemic. The commonest symptom being feeling tired or fatigued. They can have pallor, weakness, headache, palpitations, dizziness, or dyspnea. They crave for unusual things like ice and dirt, or impair temperature and regulation and feel always colder. Iron depletion without anemia the symptoms can be just feeling fatigued, irritable, having poor concentration and hair loss. So does it have any effect on the pregnancy outcomes? It has been found to be associated with increased risk of preterm delivery, low birth weight, small for gestational age fetuses, high perinatal and neonatal mortality, and lower serum ferritin in the cord blood. Does have effect on the other side on the mother. It is associated with increased maternal morbidity and mortality. It reduces the immune function, makes the mother more prone to infections, increases the blood loss. If a hemoglobin is less than 85, that's 8.5, the risk of PPH can go as high as 60%, and 1/4 of these can have severe PPH. And this is thought to be possibly due to impaired uterine contractility due to decreased availability of the oxygen. If the hemoglobin is less than 7, the mortality is increased by twofolds, and it also is associated with postpartum coagulation and emotional, that's postpartum depressions and emotional instability. What does it affect on the fetus and infants? They are also prone to iron deficiency in the first 3 months of life. They can have impaired psychomotor or mental development, negatively can contribute to infant and social emotional behaviors. And so it's important potential implications not only for that mother, but also for the future neurodevelopment of that infant. This is one of the biggest studies in which they looked into the maternal and perinatal morbidity and mortality, which is associated with anemia. It was a publication, a huge publication, in which they looked into on more than 500,000 women. What they found that the length of stay of these patients is increased in the hospital, even in the mild to moderate anemia, which can be as high as 5.4-fold higher. Transfusion risks are higher. Postpartum anemias are higher. Transfusions, whether it's antepartum, intrapartum, or postpartum, are increased. If we compare this with the severe anemia, it can go as high as 4-fold higher, whether it's a length of stay, whether it's antenatal admissions or admission to special care unit. There has been an association even with placental abruption. Transfusions, as I said before, is almost as high as 48-fold, and they requiring antibiotics for the infections. And it's same thing, there's a risk of preterm births, which could be very preterm birth, risk of small for gestational age, increased risk of stillbirth, neonatal death, and perinatal death. And this again is same as the severity of anemia increases, all these risks increase as well, much higher than the mild to moderate anemia. If I take overall what happens, there is longer hospitalization, more antenatal admissions, rate of preeclampsia, placenta previa, and cesarean delivery. And even in the postpartum period, there is increased blood transfusion rates, and it goes higher as the anemia increases, which can go up to 48-fold higher. What about preterm birth? Again, as the severity of anemia increases, the risk of preterm birth odds also increases, and that too as small for gestational age, low birth weight, and neonatal death, and even perinatal death. So again, we know it's common, anemia is quite common, but it's a reversible condition, is associated with significant antepartum, intrapartum, postpartum maternal morbidity, and perinatal morbidity and mortality. So what's important? To have a pre-pregnancy and antenatal treatment of anemia has a potential to improve the outcome of these fetuses, neonates, and minimize the illness burden and cost due to common diseases. What are the common labs you will perform is the CBC, blood film, serum ferritin, which you check less than 30, transferrin saturation, and even in future possibly maybe hepcidin test. What is the common parameters you see? I'm just focusing on the iron deficiency anemia. In iron deficiency anemia, you will have hemoglobin, low hemoglobin, you have low MCV, or at times it can be normal MCV, low ferritin, and if you do transferrin saturation, it will be also low. We did audit in our own hospital, and we found 20% of the patients who are anemic. I'm not talking about iron deficient. And more than 50% of these patients were Emirati population, and majority of them were in the second and third trimester. And of these patients, where we found 97% of them were iron deficient and 3% were thalassemics. Now, 38% of the cases of these received only parenteral iron, where there was a scope to improve their hemoglobin by giving some alternative therapies. Prevention, should we recommend all mothers who are pregnant to take the prophylactic iron? There's a debate on this. Possibly where the anemia incidence is very high, possibly we should be giving them iron tablets throughout pregnancies. What about trial of iron therapy? Yes, if you find anybody anemic, you haven't done the ferritin, you can start as first line iron, oral iron, check the hemoglobin within 2 weeks. If there is improvement in the hemoglobin, at the same time you have sent the serum ferritin, then you can confirm your diagnosis. Now, if a patient is not responding to your oral iron therapy, you need to go for parenteral iron therapy. In that situation, there are certain other conditions where patients will not be able to tolerate oral iron. These are patients who have a gluten sensitivity, or patients with inflammatory bowel disease, malabsorptive syndromes, gastric bypass surgery, or patients who are they cannot tolerate oral iron, they are intolerant to it, or then you have to go for something else, and that's where you need to, because you want to improve their transfusion risk, reduce the transfusion risk, and also improve the quality of the life. So what are the indications for parenteral iron? First of all, parenteral iron is given only during second and third trimester only to the patients, as I said before, and severe anemia, insufficient absorption late in pregnancy. We don't use any more dextran free. We use no dextran components. We use other parenteral iron therapy. There are certain contraindications to it, which is anaphylaxis or reaction to parenteral iron therapy. You don't give it first trimester, as I said before. You don't give in active, acute, or chronic infections and chronic liver diseases. There are two preparations which are now commonly used because they're single drug use, and that's single dose, and that's iron carboxymaltose and iron isomaltoside. And they are very quick to give within less than an hour and have a less side effects. So we wanted to introduce the parenteral iron because before this we were using multiple drugs dosage vials like iron sucrose. But only problem with that is as well to ask the patients to come repeatedly to the hospital for, it causes a lot of inconvenience, and also the time which a hospital requires to keep the time available for these patients to come. So we started looking into what are the better options we should look for. So the first thing we started looking for is what is the adverse drug reaction to ferric carboxymaltose. And we started looking into the different studies as well. In pregnancies, there were very small numbers of the patients which have been, and this was the biggest study, which was the 8,000 subjects. And one of the commonest symptoms was nausea and injection infusion site reactions. And one of the risks which has been which was very much alerted to all, was hypophosphatemia, which is of unknown significance. It can cause headache, flushing, dizziness, and hypertension, but the rate of anaphylaxis was rare. So we thought this is the best option which we should be using. And again, patients who are at enhanced risk of anaphylaxis are the patients who are either atopic or have eczema or have severe asthma or have history of drug allergies, or patients with systemic lupus erythematosus or rheumatoid arthritis. Keeping in mind that ferric carboxymaltose has a lot of advantages, being a single dose, short infusion time of 15 minutes, and you can give up to 1,000 milligram in a single dose. So it seemed to be a very attractive alternative. It has a very good safety profile, efficacious, convenience, and resource utilizations within the hospital. So we introduced it in 2015. We introduced in our guideline, iron deficiency anemia in pregnancy. The guideline was introduced and we started using the intravenous ferric carboxymaltose after we were convinced by looking different studies where we found it's safe, effective in treatment of iron deficiency anemia in pregnancy. And then we looked into more and more to see, is it anything better in comparison? Again, the same thing, it's safe and effective in treating iron deficiency anemia. Then it was compared with the intravenous iron polymaltose with ferric carboxymaltose. Again, the reaction rate, adverse drug reaction was less with ferric carboxymaltose in comparison to the iron polymaltose. So we started thinking, so this is the thing we should be using. So after using for 2 years, we started looking at retrospectively in our patients, and we called it as a REGAIN study, which was a retrospective study to assess the effectiveness, tolerability, and safety of ferric carboxymaltose in management of iron deficiency anemia in pregnant women, and which was recently published in 2019. And what was the main thing? We looked into 1,000 women who received iron ferric carboxymaltose, and inclusion criteria was the same, that is the reproductive age group, hemoglobin less than 11, and they had received at least 1 dose of ferric carboxymaltose, and hemoglobin was checked twice, one before and one after. Exclusion was any patient who has any hematological or any hemopoietin disorders, or those who have received other parenteral irons other than ferric carboxymaltose. Majority of these patients, 93%, were singleton, almost 5.5% were twins. The mean age of the patients was 31. Ethnicity was mainly Arabs, about 94. Mean weight was about 75. Mean systolic blood pressure was 109. and mean diastolic blood pressure was 66. So if you look into the most of the patients, we had all of these parameters, data available, whether it was weight, systolic blood pressure, diastolic blood pressure, and heart rate, because we used to check before giving the iron and after giving the iron, observing them for half an hour and then sending them home. So same thing, it appeared whether the patients have post-transfusion parameters or not. This was pre-transfusion and post-transfusion of iron. So then we looked into what was the ferritin levels was available of these 1001. We had serum ferritin available for 998 patients of that 1001. So what was the significant? This is the most important point of the study, was to see is there a rise in the hemoglobin. If you give 500 milligrams of pericarboxymaltose and the pre-infusion hemoglobin was 9.9, and then post-infusion, the hemoglobin went mean of 11.4. So there was a significant increase in the hemoglobin levels. And same was when we used 1000 milligrams, and this was again significant increase in the hemoglobin levels, and again about 1500 in patients who received 1500 milligrams, again the post-infusion, the significant increase in the hemoglobin. What's more important than that, if you give a smaller dose like 500 milligrams, the rise is not, the increase in the hemoglobin by 2 grams was only 27.5%. But as the dosage was increased, like went to 1000 milligrams, the increase in the hemoglobin was 39%. If you go up to 1500 milligrams, the rise can be as high by 2 grams in 63, almost 64% of the women. So after seeing these, I will tell you what we made the changes in the guideline. What about the side effects or adverse reactions? It's only in 2 patients where we didn't complete the therapy, and these were where they had mild symptoms and none of them had any anaphylaxis, and they continued, rest of the patients, we all continued to have the full dose of pericarboxymaltose. So our conclusion was nearly 50% of the women in this study achieved an increase of 2 grams of hemoglobin without any adverse effects. And pericarboxymaltose is same what it was before, safe and effective alternative increasing the hemoglobin in pregnant women with iron deficiency anemia in 2nd and 3rd trimester. So this was what happened from 2015 when we introduced, and we used only 1,287. I'll tell you the reason for that also. As the years passed, and we had change in the guideline in 2018, where we changed the cutoff of the ferritin. In the initial part, our cutoff ferritin was 13, and now we have changed it to 30 micrograms, which is the internationally agreed cutoff levels. And during this period, we had almost 59% increase in the use of pericarboxymaltose. And what we changed, not only so, we changed the dosages, which was in the recently 2019. And our minimum dose, which we give to the patients, is about, we give them, if they are more than 90 kilos, and they are more than 9 grams hemoglobin, and the weight is more than 50, we give them 1000 milligrams. If their hemoglobin is less than 90, we give them 2 grams in 2 divided doses a week apart. And hemoglobin levels were assessed in all patients between 2 to 4 weeks, depending upon the availability of the time after giving pericarboxymaltose. And what our conclusion was, pericarboxymaltose is preferred because it's a convenient. So as I said before, I started with the sentence, the goal of World Health Assembly is to reduce anemia by 50% by 2025, because it's important. It decreases the capacity of work, increases the healthcare cost, increases the risk of poor birth outcomes, preterm birth, low birth weight, and perinatal and neonatal mortality. And what all we need to do is to treat an anemia appropriately and appropriate time, and depending upon what's available in that particular country. So these are some of the factors or recommendations which are given by the World Health Assembly. That's to have it a plan, to have a multi-sectoral approach, strengthening the healthcare systems, and to have a community support to improve the hemoglobin in the reproductive age. And if we take the same patient, which I started with, what would have been the best option in these patients if they can't tolerate oral iron? Because of the time factor in the first patient, because she was 36 weeks pregnant, oral iron would not have been much of an help in this patient. The parenteral iron would be the best option in this patient. In the second patient, because she's raw and Y, gastric bypass, absorption is very poor, and hemoglobin is extremely low. And even though MCV is on a borderline, this is a patient where you should be checking vitamin B12, so possibly needs a combination of parenteral iron and vitamin B12. So in conclusion, anemia in pregnancy is a global health problem. It's a common condition with the serious consequences. Appropriate management, starting with oral iron, if no response or non-compliance on the part of the patient, parenteral iron therapy is the best option. Single dose therapy is the best option because it reduces the chances it reduces the patient to come repeatedly to the hospital and also reduces the hospital cost because of involving the people in making the healthcare cost much cheaper, giving us a single dose. Pericarboxymaltose is safe, effective with least drug adverse reactions and reduces the need for blood transfusion. So if you want to remember a simple algorithms for management of these anemia, this is a very simple follow. Low hemoglobin, do an MCV. If you have done a low MCV, low hemoglobin, look at the red cell count. If the red cell count is normal and low ferritin, it's iron deficiency anemia. If it's a normal ferritin, it's anemia of chronic disease. If the red cell count is high, ferritin is either low, normal, or high. In these, this could be thalassemia. If it's a normal or tending low hemoglobin, possibly normal MCV, or in that situation, look at the red cell count. If it's normal, low ferritin, it's only iron deficiency. It's not iron deficiency anemia. And the same applies if you have a normal or high MCV, red cell count is normal, ferritin is low or normal, consider vitamin B12 deficiency, check for the B12. And same is the algorithm for the management of anemia. I would say if you have time, oral iron is the best option. If you don't have a time, or if you have a severe anemia, but you have a ferritin of less than 30, please consider to refer these patients to the hematologist. And if you have a poor response, consider oral iron, consider IV iron. I think it's very important if you want to improve the health of women and the future generations. Anemia needs to be effectively managed during pregnancy, if any, or if possibility, much before they start their pregnancy. Thank you very much. I'll stop here.
Thank you very much, Dr. Salima Wani. It was a wonderful presentation about management and when to use IV iron indications and the outcome, when to measure, follow up patients. It was a thorough, excellent presentation. Thank you very much. Now we'll go to our next speaker, Dr. Hisham from Saudi Arabia. Dr. Hisham is a consultant, OB-GYN and perinatologist consultant, and he's director fetal and women health care program at Jeddah, Saudi Arabia. He'll be talking to us about Saudi Arabia consensus guidelines on iron deficiency anemia management in the peripartum conditions. Thank you for joining us, Dr. Hisham, please.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank you, Dr. Tagreed, for the kind introduction. I'd like to thank the organizing committee and VIFOR for this excellent setup of webinar. And I'd love really to join you again for this kind of activities, because really it helps spreading the knowledge among our population and improve the healthcare in the region. With regard to my talk objectives, I just gonna go through some different management options that we have for iron deficiency and iron deficiency anemia, as well as identifying the major health hazards for iron deficiency, explain the different protocols of the Saudi consensus on managing iron deficiency and deficiency anemia in women in reproductive age, and also highlight the significance of IV iron as a new therapeutic modality in IDA with great safety and efficiency, as we have just heard from Dr. Salima, which really gave a very nice and excellent overlook on the subject. Well, I'm not going to talk about the different pathophysiology and physiology. We heard actually a load of important knowledge about the significance of anemia and its effect on pregnancy outcome. But to start with, I will just go directly into the therapeutic options for iron deficiency. Well, in simply, we can correct the iron deficiency either by dietary input, oral iron treatment, intravenous treatment, and of course we have a blood transfusion option that is really open for mainly acute conditions. To start with. Now, in terms of the dietary iron, there are two types of iron that we can find in a meal, which is really the ferrous, which is the heme iron, which is usually contained in animal food like meat, liver, and spleen, or the ferric iron, which is more common and is obtained from the cereals, vegetables, and beans. Now, in any amount of food that enters the GI system, usually it's the stomach. It's the place where these iron molecules actually being extracted from the food particles. So if you don't have a stomach, then you'll know you have no iron available for absorption. And that's why patients who had the bariatric surgeries and sleep operations, really they lack that kind of mechanism to extract the iron from the food, and that's why they have they become iron deficient. So iron has to be released in the stomach first before its absorption in the duodenum and the upper jejunum. Right. Now, there are certain foods actually or products in our nutritional components that may inhibit the iron absorption, such as the cereals, the vegetables, actually also the tea, the coffee and cocoa, wine. It has been noticed that a single cup of tea taken with meal reduces your iron absorption by up to 11%. So the dietary phenols, also and phytic acids compounds bind with the iron, decreasing the free iron in the gut and forming the complexes that are not really absorbed. And that's why, that's how these phenols and phytic dietary components can affect the absorption of the iron. On the other side, we have promoters for iron absorption from the diet, which is like the ascorbic acid, because ascorbic acid reduces the iron from the ferric to the ferrous forms, which increases its absorption, and also the muscle protein. We have in muscle proteins what we call the cysteine, which are peptides released from the partially digested meat, which reduces again the ferric to ferrous salts and make it more soluble for absorption. Then, apart from dietary, we move to the oral treatment where we use the iron tablets. So you have to remember, it is a matter of replacing the iron and also treating the underlying disease. So anemia can be iron deficient, but could be due to other reasons. Maybe the woman is bleeding because of some kind of heavy menstrual period, and that's why you need to correct the original problems. But in terms of the anemia, yes, maybe you have to correct it by giving the oral irons, and usually it's the preferred route of treatment to start with, and you have to look for responses to make sure that you are really getting somewhere. So by just giving a box of oral iron to the patient and forget about it is not really practical. It's not really even legally acceptable, because you have to follow up with your patient and see whether this kind of treatment is making the benefit. And there are measures where we can really assess whether the treatment is making a benefit for her or not. And I'm going to talk about this maybe in a little while. The replacement therapy is usually prolonged. It takes about 6 to 12 months of treatment to replenish the stores of iron in your body. And also you have to, as I mentioned before, ongoing bleeding may cause definite therapy. That means if a woman is always having heavy periods, that means she needs to be always on iron to compensate for that loss of iron. And this is just an example of what we have in the market in terms of the iron salts or compounds that are available in different preparations. We have the ferrous fumarate, gluconate, and ferrous sulfate. But I just want to draw your attention to the elemental iron component of the different preparations. If you're talking about the 200 milligram fumarate or 200 milligram sulfate, they contain 65 of elemental iron. So that is in one tablet. However, if you're using the iron or ferrous gluconate of 300 milligram tablets, it has only 35 milligram of elemental iron. So that means if you're using ferrous gluconate, you have to give 2 tablets in order to be equivalent to 1 tablet of ferrous sulfate or fumarate. Keep that in mind. And here is the response. And here is how you measure your patient's response to your treatment. Now, whenever you start treatment, you have to assess that patient in a month's time. And you look for the peak reticulocyte count in 7 to 10 days should be reached. Increase in hemoglobin and hematocrit should be reached within 2 to 3 weeks. But then getting to that normal hemoglobin you're really aiming at, it may take 2 months, but for normal iron stores, it will take 4 to 5 months. So if you have this kind of a timetable or a timeline where you can actually watch your patient and measure and assess her with these kind of measures, then you know whether the patient is benefiting or not from this kind of treatment, which is the oral route. Now, the problem with the oral route that we have been seeing in all of our patients, which is the GI intolerance. It's very common that patients come to you, I cannot take the iron, it causing nausea or vomiting or diarrhea or constipation. And sometimes you don't see that she is taking it properly or she is unable to consume it. So what do? You double the dose. So in this case, consuming also large doses of the iron may move you into another or complicate the problem further by having what we call the inflammatory reaction. So within the GI tract. And this inflammatory reaction can lead to the production of interleukin 6, which is very known to be a cause of inflammatory anemia. In addition, it may alter the microbial colonization. It may also induce the oxidative stress reaction. All this inflammatory thing, actually, it can be an aggravative process for anemia, which may render these patients even more anemic. The lack of response, which is the inability to correct her hypopheremia, mostly ferritin remains low, and sometimes the hemoglobin, which is really remain low and is not corrected. However, if you have treatment failure due to absorption issues, we have conditions that many conditions we need to keep in mind also. Patients having the H. pylori infections, autoimmune gastritis, celiac diseases, gastric bypasses, and inflammatory bowel disease. Here, just a small cartoon for you to understand the concept about the iron absorption from the enterocyte, which is the cells lining the jejunum or duodenum. Now, here are 2 types of iron. The heme iron, the first type, actually is getting absorbed through the heme transporter quickly right away. However, the ferric iron heme need to be actually reduced first by the cytochrome reductase, and then traveled by the divalent metal transporter into the enterocyte cell and stored here in the cell as a ferrous. Now, some of this can really get ready to be transferred into the circulation with the as a transferrin. But here at the gate, where we need to have the ferrous being converted into ferric compound through the ferroportin. The ferroportin gate is the one that really responsible for transferring the ion into the circulation as a transferrin, reaching to the liver and the bone marrow. Now, in cases of inflammation that I mentioned before, and extra iron and causing the gastric upset and all that around the patient, that kind of inflammation lead to the release of a compound called hepcidin. Interleukin 6 causes hepcidin production and from the liver. The problem with hepcidin, it just closes or block the effect of the gate of the ferroportin gate, and that's why there will be no more iron being transferred into the circulation, leading to the plasma iron, low level of plasma iron. And at the same time, the ferrous here will be just accumulated in these enterocytes, and as you know, the enterocytes has a really limited lifetime, where every week they just get sloughed away, and all the contents of the iron really comes down in the stool, and the patient did not make use of this. So this is a situation what I'm showing to you here, how if the inflammatory process that resulted from these reactions by not benefiting from the iron and getting more iron through the oral route without any benefit, and causing inflammatory process, aggravate hair condition. That's why it's not just the lack of absorption, but also the other effect of inflammatory process lead to further deterioration to hair iron and having lower plasma iron levels, and anemia is just not treated. It's even got worse. So that's why we have to resort for certain patients to the next level of treatment, which is the intravenous iron. So we can say that indications for intravenous iron treatment is, number one, bad tolerance, which is the gastrointestinal side effects that we have talked about, and then patient non-adherence. It has been estimated that 70% of patients reported reducing adherence to treatment, and also lack of response after oral treatment. The hemoglobin is not really increasing above the 10 in 2 weeks, and also the hemoglobin remains maybe sometimes below the 9. For this reason, maybe you have to switch to the intravenous. Rapid hemoglobin requirement increase can be needed for patients really going for surgery, and that's why maybe you want to speed the process rather than waiting for the oral iron to take place to make the effect. You just resort to intravenous route. Now, when we talk about parenteral iron, we have actually a concept where we can deliver that iron from the bottle rapidly and be selectively driven into the reticuloendothelial system of the liver and the bone marrow once they pass the circulation. So here, feeding those areas that need the iron directly rather than getting absorbed through the GI. Now, in the market, we have seen 3 generations so far of the iron, intravenous iron. First generation is the low molecular weight iron called dextran, and this is not in use anymore because of the side effects that has been reported in the past. And then we have also the second generation, so called the iron sucrose or iron gluconate. These are available, but the problem with these preparations that they require multiple doses and over a long period of time. So we may need something like 8 or 12 doses of this over a period of 2 to 3 weeks in order to complete your treatment or therapy to achieve treatment that can be given once or twice, like the third generation. And here we're talking about the ferric carboxymaltose, and there is something else coming on the pipeline, which is called the iron isomaltoside. So this slide just shows you here a little bit the change in the hemoglobin after the iron sucrose treatment and the ferric carboxymaltose. And after 6 weeks of the initial treatment, we see that hemoglobin has risen 1.13 in the carboxymaltose treatment, while only 0.9 gram in the iron sucrose. So how safe? Maybe we heard from Dr. Salima about the safety of IV iron versus blood in general, but I want to compare this in particular to the blood transfusion. Well, let's look at the less serious hazards, where the UK reported that the death due to blood transfusion has been calculated to be 1 in 100,000, with also morbidity of 6 in 100,000. However, that rate was only calculated to be 0.04 of 100,000 in cases of IV iron administration, and this used to be in the earlier preparations that was Dextran was involved in this group of studies. Then we had also a better correction and long-standing. Imagine IV iron may improve functional status within 4 weeks and maintain that improvement for a period of 24 to 52 weeks. So this way, I mean, you have one single treatment that lasts you for a whole year. While in case if you give him blood transfusion, we all know that the lifespan of the RBC is only 27.8 days, and after that, all RBCs are gone. So then the most important fact that we have seen recently actually is the minimized volume of transfusion. A new concept came in the area to say that further supplementation of IV iron after minimal RBC transfusion to correct the acute stage, which is needed that time, has been suggested to compensate for the RBC half-life, leading to a better and longer lasting correction and reducing the risk of blood transfusion. So instead of giving 6 to 8 units of blood, you just give 1 or 2 just to stabilize the patient in whenever she was hemodynamically unstable, and then that will be enough for her to receive the intravenous iron, which really give her a better lasting effect afterwards. We have studies that have compared the oral route versus the intravenous route. This one came from India, in fact, and they were actually giving 2 groups of patients, one intravenous iron, the other gave them oral, and rise in hemoglobin in 2 weeks, 4 weeks, and at delivery. And you can see the improvement here is really statistically significant. There is an of intravenous route patients, and they concluded that intravenous iron treated iron deficiency anemia of pregnancy faster and more effectively than oral iron therapy with no serious adverse effects. Well, the story goes when you compare the ferric carboxymaltose versus iron sucrose, and between the two, second generation and third generation parenteral iron. In this study, they have concluded the ferric carboxymaltose has a comparable safety profile to iron sucrose, but offers the advantage of a much higher iron dosage at a time, reducing the need for repeated applications and increasing the patient's comfort. So there are many benefits of the iron of the FCM. Then talking about the postpartum anemia, we have 2 publications. The first one came from Canada in 2015, and they were talking about a meta-analysis looking at several RCTs, and they concluded that the evidence from these RCTs consistently supports the benefit of intravenous iron therapy for increasing and minimizing and maintaining the serum ferritin levels in women who have had significant postpartum anemia. In the American publication, which was just last year, 2019, again, they had reached about a similar conclusion. Then we in Saudi, I have formulated a group of senior consultants as well as obstetrician as well as hematologists, and we decided to look into the use of these different approaches, whether dietary, oral, or intravenous measures for the treatment of iron deficiency and iron deficiency in women of reproductive age. So at the end, actually, we have reached the consensus, and we published it as a Saudi Arabian expert consensus in June 2019, just last year. And whenever you see this slogan, then it means any slide related to the study itself. So the objective of our study is to identify first the three groups who are at risk of anemia. And we said that been identified as the heavy menstrual bleeding group, which are the non-pregnant group, and then the pregnant and then the postpartum three groups. And here, once we are identified, we try to establish standards for screening, diagnosis, and also treatment by monitoring those cases of iron deficiency and iron deficiency anemia related to these three different groups in order to improve the overall quality of life of women with iron deficiency and iron deficiency anemia. First of all, we have decided about the approach is how to screen. We identified two methods of screening: the primary, which is the first thing we do, and here we do CBC and serum ferritin. Recently, we have reached an agreement with the Ministry of Health to approve the inclusion of serum ferritin as part of the antenatal screen laboratories and investigations. And then the secondary screening, which whenever you have abnormal testing or sometimes maybe confusion in the results of these two, maybe hematologists maybe need to be involved. And these tests, which are like total iron binding capacity, serum iron, blood film, transferrin saturation also can be looked at and to assess the anemia of the patients. Part one, which is here the group of patients that have heavy menstrual bleeding. And in this section, we had about 26 statements related to this group or to this group of patients or of women. And we have, I cannot really go through the whole 26 statements in this limited time, but I just take some phrases here. Like, for example, statement 1.2, it says that a thorough patient history of every patient with HMB, heavy menstrual bleeding, suspected of ID or IDA should include details of history of anemia, ID, IDA, history of oral intravenous iron use, medicines use, especially the anticoagulant and non-steroidal anti-inflammatory drugs, as well as history of bariatric surgery. In section 1.3, we said that women with HMB presents with symptoms of fatigue, dizziness, palpitations, hair fall, lack of concentration, psychological distress, depression, nightmares, restlessness, and pica should be suspected of ID and IDA. And that's why, I mean, iron deficiency anemia, iron deficiency per se is not necessary to be an anemia. And that's why we may say just patient suffering from hair fall alone per se may identify her as an iron deficient person. In section 1.8, we said that all women with confirmed diagnosis of ID or IDA should receive oral iron supplements containing 60 milligram elemental iron for a period of 1 month as a first-line treatment. And then women with a 1% increase in the reticulocyte count and an improvement in hemoglobin by half gram per deciliter after 30 days are considered responders and should be continued on oral iron for another 2 months and then reassess again. So you can see here, our option always is to go for the oral iron. Then in section 1.9, we said that at 3 months, if the hemoglobin does not really increase by 2 grams per deciliter, the patient is considered a poor responder or suspected of being non-compliant and should be switched to intravenous iron. At 3 months, if hemoglobin increased but serum ferritin is still remaining below the 30, patient should be considered as a non-responder and switched to intravenous iron. In our publication, we included an algorithm, which is really simply in 2 parts, the diagnostic part for these patients with the HMB. And you can see here, first part related to the symptoms of heavy menstrual bleeding, like number of pads they soak and then all these things. And then the second section is the symptoms of anemia. So you have also to ascertain this patient is not just having the HMB, but also having maybe symptoms related to to iron deficiency or iron deficiency anemia. And once that ascertained, then the next thing is to do your investigations, mainly CBC and serum ferritin. That's as simple as this. And then you can identify whether she is just an iron deficient or iron deficiency anemia. Of course, very low hemoglobin that goes into the section of iron of blood transfusion. But for treatment, if you usually, if you identify this patient is iron deficient or iron deficiency anemia, then you start, as I mentioned before, 60 milligram of elemental iron for 4 weeks. After that, you do your text count, and also you do your hemoglobin and see if there is an increase. Yes, you continue. If not, you go down to the intravenous iron, right? You continued, then you assess her after 2 months. 2 more months, though. That means 3 months from initial treatment. You do the hemoglobin and you see if it is increased by 2 grams by then 3 months of treatment. You continue still with the oral treatment. If not, then you have to go to the oral route and further assessment of the serum ferritin. If it is below 30, you have to resort to the intravenous iron. So it seems to be that still there is a safety valve here of using the intravenous iron at any stage of your treatment. Part 2 of our guidelines or consensus is the patients who are pregnant, what we call the antenatal consensus statement. In this section, we have 34 statements. And again, I'm just going to stick to highlight some of those statements. For example, section statement 232, we said that all women with hemoglobin less than 11, which is the cutoff for anemia, should undergo serum ferritin evaluation. And in section 2.7, we said that all pregnant women should receive oral iron as prophylaxis, regardless of hematological parameters. This is really our intention here, as being really agreed upon by other authorities in the world, that universal treatment with iron is really helpful, because we have estimated that 30 to 40% of pregnant women start their pregnancy being an iron deficiency, with iron deficiency or even anemia. In section 284, we said no more than 1 tablet containing 60 milligram of elemental iron should be dosed per day. So here again, we have really found that the giving and double the doses or triple the oral tablets is really of no benefit. You may even cause the patient more harm, and even she just lack the response, and then one day you find her anemic and she's in labor, whatever. So it's very important that you rely on 1 tablet and look for the improvement in her parameters. Now, in general, these are the recommended iron treatment in pregnancy according to the Saudi guidelines. For oral treatment, all patients should receive a trial of oral therapy, 60 milligram elemental iron, for at least 1 month before moving to intravenous iron. Now, intravenous iron treatment can be a second-line therapy or even first-line therapy. As a second-line therapy, which is usually those patients who've been initiated in oral treatment and they were poor responders or non-compliant or whatever, and you have to resort to intravenous. But there are certain patients whom really you don't need to play with regarding oral treatment or taking her down that path. You just give her intravenous iron immediately, and these are the 5 indications for that, according to the consensus. Patients is intolerant to oral iron or non-compliant. We always have our clients who really come to us one pregnancy after the other. So you know your patient. You know this patient is not good for taking the pill, or she cannot really handle the oral iron. You know her from previous pregnancy. Why you put her through the same agony and give her another tablet of oral iron? Just go straight for intravenous iron. Now, patients who has undergone gastrointestinal or bariatric surgery, again, there is no point of fiddling around with that one. Patient, you know, if she lost most of her stomach, and that's why you just give her the intravenous iron. Patients need a rapid increase in hemoglobin. For example, patients scheduled for surgery, and then patients after 32 weeks with gestation with a hemoglobin of less than 10. So this is just because of the limited period of time remaining for to end her pregnancy at the time when she may go into an insult of hemorrhage. So if she's reached 32 weeks and hemoglobin is less than 10, don't start oral iron. Just go and give her an intravenous iron. Patients expressing a preference. Again, this is patient's right, I think. She told you, no, I know myself, just give me an intravenous iron, I'm prepared and happy for it. I don't want to take oral iron. Go ahead and give it to her as an intravenous line. Blood transfusion, our recommendations in the consensus states asymptomatic patients with hemoglobin less than 5 grams per deciliter may be considered, but patients at high risk of bleeding with a hemoglobin of less than 6 should be considered for blood transfusion. We also included two regimens or practical guidelines on how to prepare the solutions, whether it is an iron sucrose like in this one, or for the ferric carboxymaltose like in this one. So both preparations are included in our publication, and you can go and see how exactly you mix your calculate your dose. And I just wanted to remind you with two things. Number one is that having a hemoglobin of 12, 13, or even 14 is not a contraindication to give ferric carboxymaltose as long as her ferritin is low. So low ferritin is your guidance to give ferric carboxymaltose. And the other thing is the duration of time. We patient in the nurses, sorry, in the ER tend to be scared not to give the high fast drip. This patient may get reaction. On the contrary, the longer you keep the drip running, the higher the chance of having the reaction, and that's why you always finish your dose within between 6 and 15 minutes of throw. Again, in the antenatal group, we have identified an algorithm. As you can see here, it is the diagnostic part, which really you can see you do the CBC as well as the ferritin, and identify different type of patients, whether it is iron prophylaxis in case she is normal, everything is normal, but we said we have an eligibility to give patients universal iron, or identify her as anemia or iron deficiency. If there is any confusion in the results, then you do the secondary testing. And if it is iron deficient with the help of a hematologist maybe, then you start the treatment. The recommendations here actually for treatment in the first trimester, always oral iron. Till today, we don't have the green light really to prescribe intravenous iron in the first trimester. Not because we have seen teratogenic effect from intravenous iron. No, it hasn't been reported, but still we didn't have a report to say, yes, we have used it many times, 100 times, 1,000 times, and there was no iatrogenic effect. So we need to wait for that fact. Maybe, I hope very soon we're gonna see publications coming through to give us reassurance to give the intravenous iron in the first trimester. Second and third trimester, of course, as I said before, you start, once you have identified your patient with iron deficiency, start oral treatment first. If responding, continue. If not responding, go to the intravenous route. And then the part 3 of this study, which is really looking at the postnatal group. And here, of course, we have the patients after delivery. All you need to do is look at her hemoglobin. If hemoglobin is less than 9, straight away given intravenous iron. If her hemoglobin is between 9 and 11, of course, you may give her a course of oral iron, but check her at the 6 weeks visit when she comes to you. If it is still low, then you have to give her the intravenous iron. I have the tendency actually with the patients of less than 11 at the time after delivery is to give them the intravenous dose before she goes home. It's just one single dose. I know if I give her oral iron, she is busy with a newborn, she's busy breastfeeding and other family issues. The last thing she remembers is to think about herself. So really do this lady a favor, give her the intravenous shot of iron before she goes home, and then you can assure that she'll recover very well and have and boost her iron. Finally, I reach my conclusion of my presentation, which is really the summary of the Saudi consensus on managing ID and IDA in women of reproductive age. We have identified 3 vulnerable groups of women in their reproductive age to iron deficiency and iron deficiency anemia, namely the heavy menstrual bleeding and the antenatal and postnatal women. Screening methods, along with timely intervention with the appropriate treatment in each group, is outlined according to the international standards and with the specific consideration of the applicability to the region, in the region or in our region. Well, I think these are my references, and thank you very much.
Thank you very much, Dr. Hisham. It was a detailed presentation of physiology, biochemistry, treatment, management, guidelines worldwide, and guidelines latest in Saudi Arabia. It was an awesome, very interesting, detailed presentation. Thank you very much. So I don't need to present mine, يعني خلاص. You went through all the aspects of iron deficiency anemia management. So now the presentation of iron deficiency anemia in Latif Hospital. I'm receiving a lot of questions from the audience. I'll try my best to be short. Okay, and to the point. So, can you hear me? Is it clear? As you all know, Dr. Salimawani and Dr. Hisham went through details and definitions of iron deficiency anemia by WHO. ACOG, first trimester less than 11, second trimester 10.5 because of the dilution, and the plasma volume is much more than the RBCs. Third trimester is 10.5 to 11, and now we would like to have it 11 in Latifa Hospital, and postpartum less than 10 considered anemic. But we have to consider, I'll be focusing on some practical points in the management of iron deficiency anemia. Like a patient, her baseline is 14, for example, Caucasian patient, and now she is 11. So by definition of the WHO, she's not anemic, but in compared to her baseline hemoglobin, she is anemic. So we should always consider to go back to the flow chart or the flow sheet in the system and find out whether she was much higher than this, and this is low for her or not. Then she is considered anemic. Then we'll go and do the workup, whether it is ferritin and so on, or hemoglobin electrophoresis. The factors, again, they're contributing to iron deficiency anemia: insufficient dietary diet, and we have a lot of Indians in UAE, vegetarian, and the blood losses in the previous pregnancy. If the patient gets pregnant within 1 year, for example, and then we should ask her, did you bleed in previous pregnancy, previous delivery, or postpartum? Or she has, it's common to have short inter-pregnancy interval in our community. So we are at higher risk of having iron deficiency anemia in our population. And, you know, our requirements and demand increases in pregnancy. Whom to screen? To screen, it has been agreed to screen by all guidelines the high-risk patients. Who is the high risk? Again, previous diagnosis of iron deficiency anemia, it's common in our community. Diabetic patients, common in our community. Smoking, HIV, inflammatory bowel disease, multiparous, it's a common in our community. Short inter-pregnancy interval, less than 6 months, it happens in our community. History of abnormal uterine bleeding, underweight and obese, it's common in our community. And vegetarian, we have this population. So it is really common to have patients of high risk in our population community. And we would love to have the ferritin as a screening in our booking, but it's not yet implemented. And I'm happy for you, Dr. Hisham, that you are implementing that, and you have the agreement from the Ministry of Health to implement, to have the ferritin as screening. Now, you know, best test to diagnose iron deficiency anemia is ferritin, which is not affected by oral medications. For example, when you take oral medication, it's not affected, so you can measure it, and it's sufficient to reflect the iron stores of the body. You know, we have normal iron stores in liver, kidney, and our tissue, internal tissue. So this reflects the enough stores you have or not, or enough level of ferritin, and then to make more hemoglobin. Now, I'll have few cases that we are facing daily. This case is reflecting the seriousness of the condition. We don't actually, unfortunately, we don't take it serious till now. We don't educate our patient when they deliver that you are anemic, you have to fill the stores postpartum, and you don't get pregnant unless you have normal hemoglobin level and normal ferritin level. Actually, we don't do that. And in the peripheral health clinic, patient comes late for booking so that the doctor in the peripheral health clinic cannot catch her early and treat the iron deficiency anemia early. And then she comes to the hospital with enough stores or enough hemoglobin level. So we have a lot of gaps in treating iron deficiency anemia actually till now in our community. For example, you are called as a medical physician because I'm internist. Our team is medical team in a maternity hospital looking after medical problems in pregnant ladies. So we receive calls, like for example, we are called for severe preeclampsia in labor suit, and she is 35 weeks, and her hemoglobin is 8.1. What comes to our mind is HELP syndrome. Is it HELP syndrome because she is severe preeclampsia? No, it's not HELP syndrome. It is not the typical of HELP syndrome. And if you do the blood film, this confirms that it's not HELP syndrome. And no other blood tests are not supporting blood HELP syndrome. It's only simply iron deficiency anemia. Previous hemoglobin was 9, not treated well. She had a severe preeclampsia, and this anemia predisposes this patient to preeclampsia. And this is a common scenario. Why she had preeclampsia? Orally, we don't know. It is because of the anemic patient are more prone to have preeclampsias. Case number 2, called to see a patient in accident emergency, 30 weeks pregnant, with fever, chills, rigor, blood pressure 97/56, respiratory rate fast, 26, and her creatinine is high, bilirubin is high, less urine output. So you're diagnosing this patient as sepsis, and her hemoglobin is 7.7. كم التغريد. Sepsis can cause low hemoglobin through hemolysis, hemolyzing the RBCs intravascular by the cytokines after the fight between germs and the body defense mechanism of immunity. And then you will have hemolysis. This is the drop of hemoglobin because of the sepsis. No, actually 1 month back she has anemia, and her anemia predisposes this patient to have sepsis. Now, case number 3, called to attend patient in accident emergency, 28 weeks, second attack of SVT. SVT, AF, VTAC, they are more prone or sinus tachycardia, fast sinus tachycardia, simply because of the anemia, and her hemoglobin is 9. Or simply palpitation that annoying her, and then you will give her beta blocker, Indral. I've seen many patients are on Indral, bisoprolol, propranolol, and then the original cause of her palpitation was not handled well and not treated well, like iron deficiency anemia. Case number 4, 31 weeks pregnant, admitted with preterm labor, called to attend as hemoglobin was 10. Last visit 1 month back, her hemoglobin was 9.1. So this patient is beta thalassemia trait and with ferritin 12. So this patient has a combined case of beta thalassemia trait and ferritin, but her, actually this should be the opposite, 9 and 10. But her part of iron deficiency anemia was not handled well. Now, I'll not go through the effect of anemia on pregnancy. There is a lot in maternal. As we said, the cases I went through, preeclampsia, palpitation of antepartum hemorrhage, postpartum hemorrhage, are more prone to increased cardiac output, cardiac decompensation, cardiac failure, ischemia, MI, sepsis, preterm labor, cognitive and affective dysfunction in the infant. This is really sad to have a generation. If Dr. Salima Wani said more than 50% of our population Emirati were anemic. So It's really sad to have this number, huge number of iron deficient anemia pregnant ladies, where the new generation and the offspring will be having, might be having iron dependent, um, delayed in the neurocognitive development. Because iron dependent neurogenesis is maximum during the third trimester and early neonatal life. So if the mother has anemia and she reaches the third trimester with anemia, this will affect the neurocognitive development of the baby, of the neonate. Serum ferritin, as you know, less than 30, this is sufficient to confirm iron deficiency. If it is more than 30, then find out another reason. We are, yani, we have cases where it is labeled as iron deficiency anemia, but they are not. For example, if extreme microcytosis, then suggestive of thalassemia. If she has done hemoglobin electrophoresis premarital, then you go for hemoglobin DNA analysis where you can find alpha thalassemia. If she's having macrocytosis, then vitamin B12 folate. If she has retics, maybe she's having hemolysis, some sort of anemia, sickler, or other hemoglobinopathies. If she's having thrombocytopenia and neutropenia, for example, why she's having low platelet and she's having anemia. I have diagnosed thalassemia intermediate patient with, because they referred to me because of anemia and thrombocytopenia, and then I referred her to abdominal ultrasound. She had splenomegaly, and I've done hemoglobin DNA analysis, and she came into thalassemia intermediate. Abnormally high white BCs, we have diagnosed leukemias and referred to as anemias. Abnormal RBCs, diagnosed as, for example, hemolytic anemia, autoimmune hemolytic anemia, and the Coombs test will become positive. And failure of anemia to be corrected by iron supplementation. This will again alarm that you have to find out another cause. This is not a simply iron deficiency anemia. She might be having another cause of her anemia. Oral iron versus IV iron, I think you went through. We generally start in Latifa Hospital with oral therapy. Patient can tolerate it, and preferably to start in first trimester. And IV iron, we don't start in first trimester because the safety is not yet confirmed. And the IV iron given to patients with severe anemia, late in pregnancy, oral iron doesn't work, or no rise in hemoglobin ferritin. Recommended dose of oral 40 to 200. Sometimes we play around, or if she tells you I have side effect, okay, you can take it alternate. Okay, you can take the serum, I mean the liquid preparation. And especially if she will have any adverse metallic taste, gastric irritation, nausea, diarrhea, if she's having constipation, laxative, if she's having, you can widen between the timing, give her, extend the interval between the doses, switch to a liquid, switch to IV. So you do your maximum each visit. If she follow it really very, it's very important to follow your therapy effectiveness. Did it work or not? Was it effective or not? Patient compliant or not? Find alternate method, find alternate therapy. Just follow it. You don't need her, you don't want her to come with premature contraction. You don't want her to come with premature labor. You don't want her to come with sepsis. You don't want her to come with preeclampsia. You can prevent all that by really following her very strictly, I mean, very well for her, for follow-up and the effective dose. When not to try the oral, again, the bariatric surgery, NY, bypass, the inflammatory bowel diseases. The IV iron is safe in second and third trimester, but not in the first trimester. 13 to 14 weeks onward, we can give, and it's effective, much lower frequency and adverse effect than the oral sometimes, and negligibility of low frequency of serious side effect. Better efficacy and fewer adverse side effects. When to give, when she cannot tolerate, when the iron doses are not effectively increasing the hemoglobin, severe anemia. And for example, she comes to you at 30, 35 weeks and she's severe anemia, and you are trying the oral iron. It doesn't work. You have to hit strong and fast. Patient who are symptomatic, she's having palpitation, giddiness, weakness, and then you are trying the oral. Again, you have to hit fast and strong. Insufficient time after 30 weeks, history of bariatric surgery, again to IV iron. When do you expect the rise? 2 weeks, 1 gram of effective iron, oral iron, and IV iron repeat iron parameters 4 to 8 weeks, because sometimes if you repeat ferritin, it will be very high immediately after giving the IV iron. You need to wait quite some time to repeat the ferritin, but you expect the rise into the hemoglobin soon. The duration, once the hemoglobin has reached the normal range, continue giving the patient replacement of iron for 3 months. This is very important. Patient will say, okay, I'm now hemoglobin 11. I don't need to take tablet anymore. She's in 7 month, or she doesn't need to take the tablet. No, you have to stress on that you have to continue after reaching the normal level to 3 months to fill the stores. And postpartum up to 6 weeks. Sometimes I really give it to patient up to 3 months or 6 months. Thank you very much. I went through it very fast, and I hope it was clear. Thanks a lot. We need to go now to our fourth speaker, Dr. Atif. He'll be talking to us. Dr. Atif is a senior consultant in gynecology and obstetrics at Latifa Hospital, and he'll be talking to us about patient blood management on women health condition. Thank you very much, Dr. Atif, for being one of our speakers, and the mic is with you.
Okay. Thank you, Dr. Taghreed. Thank you all the thank you, Dr. Taghreed. Thank you all the board, Dr. Hisham, Dr. Salima Wani, and thank you, Mr. Rezek, for this nice. Thank you for all audience. I would like to go to speak about this blood or patient blood management on women health as a part of this activity. Thank you, Dr. Taghreed. As you know, I came from Latifa Hospital, one of the big main tertiary hospital for women care at UAE and here in Dubai. It is a hospital really large and has a lot of load of work and accepted a lot of high risk cases of pregnancy. And it had been announced very well equipped centers for high risk pregnancy and gynecological surgery. And recently is a center of excellence in management of placenta accreta and percreta, which really a bloody film and one of the concern of the management of patients with blood and blood transfusion issues. I have nothing to disclose and no conflict of interest for these presentations. Patient blood management or blood patient management is a application for evidence-informed medical and surgical concept, and it has been designed mainly for maintain hemoglobin concentration and optimize the hemostasis with minimum blood loss, and all is an effort to improve the patient outcome. The objective of this talk is here is give an evidence-based best practice and the bundle of patient blood management in obstetric and gynecology, and the patient blood management in maternity and outcome of that pregnancy in a form of any concern morbidity or mortality. For the patient blood management modules, in general practice, we have 6 modules. The obstetrics and maternity modules is modules number 5, but generally it should be applied in the critical bleeding, massive transfusions, the trauma centers, preoperative sites, whatever the specialty of the surgery, and in medical, whatever the medical like oncology or medical case of hematology or whatever, as well as in critical care, especially when the blood transfusion is needed as a part of malignant sepsis, and we know the critical care units, how the load of work there and the need for blood and blood management. And we have this pediatric and neonatal population as well. I think we have some issue. So we would like to minimize the preoperative bleeding issues and to reduce the requirement for blood transfusions, but still blood transfusion when is needed is really mandate itself by whatever indication, especially as active bleeding. As well, would like to reduce the perioperative morbidity and mortality and reduce the duration of hospitalization and the cost in the hospital whenever we have this patient, especially well prepared before. Implementation of BBM, اللي هو blood patient, I mean patient blood management in obstetrics provided opportunity to minimize. Let me to bring this down. Sorry for technical issue. And minimize bleeding and blood transfusions. So due to risk of obstetric hemorrhage, and this is, let us start by the word obstetric hemorrhage, which involve antepartum hemorrhage, intrapartum hemorrhage, and mainly postpartum hemorrhage, which is inherited for any pregnancy. So any pregnant lady, she's at risk for bleeding. So patient blood management is particularly important in obstetrics and has a lot of challenges in obstetric practice. And those challenges will be later on mentioned in details here. And with the full respect of other specialty, we do believe this management of such patients by this patient blood management is very important in our specialty. And this patient management will be start mainly even from antenatal care. And this is a good time for the patient to be well prepared when she is at risk for bleeding. If we take it as a multidisciplinary approach for the management of the patient through assessment of the development and management plan, we need to optimize patient-owned blood, identify and address the health conditions that may lead to blood transfusions or may lead to blood loss or the anemia, especially like anemia and iron deficiency anemia. Minimize the way of the blood loss, such as surgical technique, and to reduce the blood loss. Here is very important. We need a proper training, proper skills to improve the patient outcome. And to optimize the tolerance for anemia. With appropriate management, the body may tolerate anemia without restoring the blood transfusions. And this depends on the body build, the nutritional conditions. And I think Dr. Taglit covered this part in her previous nice talk. This management should be standard care applied for all clinicians for the patient facing medical or surgical intervention who are at risk for significant blood loss. And unfortunately, we have a lot of diagnoses in obstetrics like placenta previa, like patient at risk for development of the bleeding, whatever the risk factor for that. And those need special care from early and preparation, which might be needed for such condition when bleeding happens. I think no need to go in depth on the physiology of the pregnancy because already covered by Dr. Salima. Thank you for her. But quickly, in pregnancy, a range of physiological modification in the hematodynamic and cardiovascular and coagulation and fibrinolysis systems may occur in blood, and this is prevent some of the blood loss during pregnancy, during labor later on, and this is by plasma expander and other, RBCs. In the cells volume. In spite of that, still the body adapts the new physiology during pregnancy, but still the risk for postpartum hemorrhage and bleeding during childbirth is risking most of the women all over the world. The hemodynamic changes here, we can see the modification in the hemodynamics of cardiovascular coagulation help in the prevention of this blood loss during pregnancy by plasma expander and increase of the RBCs, as I mentioned, about 20%, especially in the maximum time during the late trimester, and accompanied with this plasma volume. But apparently the volume is more than the RBCs volume, and here we see apparently some sort of hemodilutions, and this gives the hemodilution anemia, which is part of the physiology of the second trimester in the pregnancy. In the first months of pregnancy, the RBCs mass is about 25% or 20 on average, followed by the drop of the childbirth or after childbirth due to peripheral hemorrhage. And this increase in the RBCs must really encourage or give enough oxygen for the tissue and the perfusion of the tissue. Advantage of this physiological changes give better perfusion for the new organ, which is the placenta and the fetoplacental unit, and minimize the risk of the thrombosis, although the coagulopathy status of the pregnancy being risk for VTE or the thrombus formation, and give adequate blood supply to ensure this, to ensure bleed, despite the bleeding that occurs to the childbirth, and still the uterine artery blood flow at that time is the maximum of almost 10 times, about 750, and this is one of the problem of the risk of the hemorrhage, that the blood will be lost, not like the other conditions will be massive. As well, there is increase in the clotting factors and other fibrin, and this is keeps the coagulopathy status of the pregnancy. This uterine artery, increase in size, increase and a lot of vascularity here, keep the woman at risk whenever the bleeding is starting. In general, why women need this type of management? Number one, women are continuously loose, if not well substituted, during menstrual disturbance or menstrual flow, even the normal. Early pregnancy issues. And here you can describe the woman health in the obstetrical part and in the gynecological part. So looking for the menstrual disturbance, looking for the menorrhagia and abnormal uterine bleeding, and being at risk for gynecological tumors, especially endometrial cancer, it means loss of blood. Those conditions need, there is a time to manage them. There is a time to look, although they may come late, but at the end, it's the elements of chronic anemia, and most of them, they are not in active bleeding. They may continuous bleeding, but not actively or life-threatening, most probably, unless she came late with anemic heart failure and so on, or as a part of the pathology of the cancer, or whatever the site, ovarian or cervical or endometrial. But bleeding in early pregnancy, most of the time, at the time of discovering of the pregnancy, like an ectopic pregnancy, sometimes patients become shocked internal hemorrhage, or even rupture ovarian cysts without any pregnancy at risk, or scar pregnancy, early just formed pregnancy as the size of the previous scar, miscarriage, whatever, incomplete and inevitable bleeding, so it may cause very bad bleeding, retain productive consumptions as a part of peripartum or postpartum time, or maybe in early pregnancy, and this is risk for another thing like perforation after manipulations, for evacuation and so. So those categories of patients are more risk for bleeding, along with the majority of the risky and morbid cases in the late pregnancy presenting by antepartum hemorrhage, whatever the diagnosis for that, like a placenta with massive bleeding from placental bed, and placenta previa, placenta accreta, or morbid uterine placenta, or newly named as placenta accreta spectrum, and this is cause very bad antepartum hemorrhage, sometimes most probably intrapartum hemorrhage during manipulation, during deliveries, and the most serious thing is the sequel for that postpartum hemorrhage, which will be life-threatening, and here we need the patient to be well prepared. Her hemoglobin is high, her anemia will be well managed to face or to withstand that amount of loss, or at least can cope or to minimize the risk for blood transfusions. Still, blood transfusion is a life-saving conditions, is life-saving, management, but it still carries risk. So anemia itself is a disease or symptoms, or comes as a sign sometimes. So whatever anemia, need transfusion, blood loss here and there, this is a viscous cycle, keeps the patient at risk for our intervention, and do prefer to prepare the patient and avoid anything. During pregnancy, I will concentrate here on the obstetrics and mainly the bleeding associated with the time of delivery and after. Clinically, the anemia during pregnancy, for starting with the first trimester after the postpartum period, categorized in the first trimester when the hemoglobin reading is less than 11 grams per deciliter, or going for the second and third trimester, 10.5 grams per deciliter. And if anything less than 10 grams per deciliter during perineum, this is defined as anemia. regardless the patient is symptomatic or not symptomatic. So we need to be support here. And antenatal time assessment during the pregnancy, we usually request hemoglobin and complete blood pictures. And as mentioned by Dr. Hisham Arab and already implemented in their system, thank you for that initiative. And also with Dr. Tagreed, that ferritin level can be part of the screening test for that. Here in the patient blood management and obstetrics, we have three main pillars: management of the patient during pregnancy, and expert speakers before me they also mentioned almost this, if not part of that. And measurement, our measures should be taken during delivery and precautions, and measures during or after delivery, at the postpartum phase. Whatever the event through, accompanied with that, like delivered by cesarean sections or any further manipulation, it will come later. So the measurement during pregnancy already covered, that identification of anemia, see people who are at risk, and here it may start before or during preconceptional period for those who already have hemoglobinopathy issues and known to be with some hematological problem like thalassemia, sickle cell anemias. Those people should be well prepared preconceptionally and go through the pregnancy and early times of pregnancy, especially during the time of the nausea and vomiting when the input will be very poor. Those type of patients will be prepared before and during pregnancy throughout. So by the prevention of the anemia, management of the anemia, and treatment of the anemia, especially the iron deficiency anemia, and further investigations that to detect the type of anemia, and maybe there's a good chance to go further for instance. And by the way, some of the malignancies like leukemia and lymphomas being diagnosed during pregnancy by the simple early investigations. So during labor, at the time of the blood loss, administration of uterotonic agents, and here mainly the oxytocin, is very important with full respect for all authors, all the the guidelines and protocols to replace oxytocins by other agents. It is good, but in the preventions, still oxytocin is one of the first options, and as well on treatment of hemorrhage. Number of very simple, very cheap. I know you need a lot of, cold chain and so, but after and during labor, it is still, plays a very important role to minimize the blood loss by good or enhanced uterine contractions. And in case of occurrence of postpartum hemorrhage, we use a modern, measure to minimize blood loss, including the balloon and everything, tranexamic acid and fibrin. All options are all, modalities and choices to minimize the bleeding. And after delivery, still continuation of uteric agent very important. We give iron supplement, we administer the treatment sometimes if we need it, and we need to optimize patient physiological response to anemia and the coming time, maybe the infections, and we need to maximize the oxygen delivery to the tissue, and this is very important. Sometimes blood transfusion here is needed. During during postpartum period, the early postpartum period, we need to identify the risk of the postpartum hemorrhage and to see it is active and heavy bleeding or non-active phase. So most of the patient who's in an active phase, the modalities of blood transfusions or blood product, it is an option to save the life. But after that times would be past safe, inshallah, the non-active bleeding phase is unnecessary for RBC transfusions, and it is really restrictive for blood transfusion. And in this case, intravenous iron supplement or even oral supplement seems better option than the oral supplement, but still you can give both of them. It depends on the amount of the bleeding and the amount of the loss and the expecting of the coming time after transfusions or after the end of the active phase and starting of this non-active phase. As you mentioned, antepartum hemorrhage, postpartum hemorrhage, and all of them here is a problem for the blood transfusions and management accordingly. What is the cause of postpartum hemorrhage? We knew very well the uterine atony is the most 70% of the cases because of uterine atony, and this is why implementation of the proper uterine agent is the policy and guidelines for all on different organizations, different institutes. Something now it is almost mandatory, and in all life-saving courses, especially in the advanced life cycle of obstetrics. Management of hidden product, like especially in case difficult, the placenta breve, placenta accreta, percreta, or simple delivery and some cotyledon missed inside or remain membranes. And in case of trauma as well, like uterine rupture or cervical tear or vaginal tear or perineal tear as well. And the rare things that may occur as a complication of the blood loss. It happens sometimes as coagulopathy and disseminated intravasculars. It may be sometimes by chemically by only disturbance of the fibrin levels and coagulations, but it can be detected. And however, postpartum hemorrhage can occur in every pregnant woman, and most women, like 60%, we do have, postpartum hemorrhage don't have risk factors. So it may be idiopathic and without risk factors. And although people may prefer vaginal delivery from cesarean section, but no difference between cesarean section and vaginal delivery for the occurrence of the postpartum hemorrhage. The mode of delivery is not affecting the postpartum, but still cesarean section is at risk. And on the other hand, people do cesarean section will be aware of the postpartum hemorrhage. So, for example, uterine neotonia cannot be predicted by, go for cesarean section better than vaginal delivery, but still no clear randomized control trial to see what is the risk more. But the cause of the cesarean section maybe is the risk for postpartum hemorrhage. And deficiency anemia in pregnancy already discussed by our colleague, but anemia is frequently in pregnant women and most associated with iron deficiency. And people at risk here, maybe other, as I mentioned, hypertensive gravidarum, risk of infection, people with infection. And nowadays we have these pediatric surgeries. Still is, considered as a risk because as malabsorptions, especially when they do that surgeries, they come in early pregnancy, nausea and vomiting, and even their absorptions, is not like to the standard because of a lot of changes in their GITs. So they may be at risk definitely for anemias. So we need to detect people at risk during antenatal care and to, management of risky patients before any occurrence of severe form of anemia that mandate blood transfusions. And this is not only at the iron and other vitamin like P and others. So it may need a lot of supplement. So we consider the hemoglobinopathies and infection wounds, especially in the developing countries, because of malaria, because of hookworm infestations, because of vitamin deficiency as general, and especially when there is, people have nutritional deficiency or have a certain habits in their, nutritions, and we have patients with chronic inflammations, as I mentioned, malabsorption condition like pediatric surgeries. So during antenatal care, complete blood count at the beginning of the pregnancy and another once again at 28 weeks, late pregnancy is very important, and in between we can do something accordingly if we need. And the reasons for the low hemoglobin level should be clarified and be questioned before anything, and then we can do the supplementations. Anemia during pregnancy mandate hematological studies, so this is very important, and we can support the clarification of the cause of anemia. It is microcytic anemia, maybe due to iron deficiency anemia or hemoglobinopathies, and macrocytic anemia maybe because of specific nutrition like vitamin B12 or folates, or normocytic anemia related to the maternal disease or infections. Prevention and treatment of antepartum anemia or iron deficiency anemia. This is recommended by WHO. The amount of iron is 30 to 60 milligram per day for all women. And in low resources countries, this is supplement will be throughout, and this is very important and highly routine practice and supplementation of such dose of iron, and it will be considered as appropriate strategies. And iron supplement may be cause undesirable, have a lot of side effects and gastric pains, and some this are not tolerated by almost 25% of the patient, if not even more. And here maybe the substitute maybe the parental one, but not in the case of mild anemias. I'd recommend it to check the serum ferritin at the beginning of the pregnancy. It's been recommended, and we have to see part of our practice, and especially if we offer oral supplementation, and when the serum ferritin is below than 30 in the level, or it could be considered less than normal level. It is also applicable for iron deficiency without anemia in early pregnancy to give the supplement, and in a woman with mild to moderate iron deficiency anemia during the first and the second trimester, it is advisable to have a daily iron supplement. The intravenous iron is recommended whenever this oral route for administration for iron preparation is not, well tolerated by the patient in case of very bad gastrointestinal side effect, or when the hemoglobin is not increased in an unexpected way, or in case of severe progressive anemia less than 9 or blood transfusion are not an options, and sometimes in a special condition like Governance witness, also you need to give the parental route, the parental route of iron supplement, it will be the options. During delivery, we need to see who at risk, older age, laboring women, patient with multiple pregnancies, especially now a lot of the assisted reproductive techniques, so we used to see the multiple pregnancy more frequent, patient with serious morbidity like preeclampsia or serious pre-delivery condition like preeclampsia, patient with for induction of labor, patient with polyhydramnios, expanded uterus, more risk for bleeding, approach placenta and postpartum hemorrhage, and patient with placenta previa. And by increased number of primary cesarean section, we have a lot of placenta previa and placenta accreta percreta spectrum, and we saw a lot of patients nowadays of such diagnosis, and really it is affecting the health system by the burden of the need of the surface, the blood transfusion. Sometimes we need the massive blood transfusion even to activate the massive blood transfusion system, which is really something we do like to avoid it. The mode of delivery, as I mentioned, cannot consider as a predictor for postpartum hemorrhage, although cesarean section is associated with a high average of blood loss compared to the vaginal delivery. Typically, blood loss underestimated in around 50% of the cases, not normal exactly to be managed. And this is whatever the technique used to assess the blood loss during labor or during cesarean section is still the underestimation of the blood loss is there. Blood clotting, like blood collection bags, this is or Tuesa swab, a lot of things is not that 100% accurate, but is much better than others. And rapid and appropriate management in case of postpartum hemorrhage is crucial to reduce the morbidity. So in treatment of postpartum hemorrhage, which is the main concept here in our talk, really, especially the severe one, we need to improve whenever the cardiac output is decreased, hypotension, we need to improve the cardiac output and the vasoconstriction effect, and because this decrease in end organ perfusion, this decrease in vasoconstrictions. So improving of the cardiac output, and this is the balance of the in the pathophysiology of postpartum hemorrhage, and especially the kidneys and the heart and the brain. So fluid management is very crucial here, and although it will mask anemias, and or primary measurement for like emptying of the bladder, massaging of the uterus, use of hygienic agent, especially as oxytocin, and to be maintained for a while is very important here. And all other options like tranexamic acids, whatever can help in the management of postpartum hemorrhage, early prevention and treatment. So here in the patient blood management and obstetrics, we do like to see the medical strategies and surgical strategies. So the medical strategies almost discussed here, like antepartum by correction of anemia, intrapartum use of hygienic agent, and active coagulation management in case of postpartum, here adding by this tranexamic acid, and we'll come later to speak about tranexamic acids, and the postpartum by correction of anemia and avoid unnecessary blood transfusion. On the other arm, we have the surgical interventions. Without blood transfusion, we need to improve the surgical technique to minimize blood loss, whatever the available instrument, whatever the available training and skills. And balloon, especially very important to bridge the time from the transferring the patient still to the theater, for example, the compression sutures and the embolizations and cell salvage is very important. And autologous transfusions is still here, no any intervention like a hysterectomy, where try to avoid that massive blood transfusions for the patient. Tranexamic acid, it is of great value. Some people believe on it, but it's still the randomized control trial for that. I mean, or no enough data to prove. Some people believe on that, but I think it is of value to minimize. I mean, the out in the case of management or prevention for postpartum hemorrhage. Red blood cells, especially transfusion, very important. The active phase of the bleeding, and especially when the hemoglobin is less than 6. And the people do believe to transfuse when the hemoglobin is around 8 grams per deciliters. And anyhow, all the authors or the guidelines agreed the need of blood transfusion in active phase, or there is a when there is a drop in the hemoglobin massively, or if the patient is symptomatic. We spoke here about the active postpartum hemorrhage. So sometimes in active phase, the blood transfusions as RBCs is mandatory, and the other product also may be needed. Like fibrinogen concentration is very important because they don't like to jeopardize the coagulation of the fibrin, and he will disturb and keep the patient in the viscous cycle, especially when they develop a clear DIC and bleeding tendency. So the fibrinogen should be in the normal level above 150, and this is very important. I mean, to stop the secondary phenomena of the blood loss. Transfusion of fresh frozen plasma is very important, and we don't like as well. I mean, it is not on the top of the fibrinogen, but still it works, and very, I mean, help in the in treatment of hyperfibrinogenemia. But as it is become I mean, freezing and need time to be organized, this is one of the, I mean, drawbacks. But as that is very, I mean, fresh frozen plasma is really recommended. The surgical intervention and strategies becomes at the second line of the management. And it is possible for the management of the majority of the severe postpartum hemorrhage when blood loss is rapidly minimized and stop using appropriate methods with eutheric agent. So we use to manage the postpartum hemorrhage in synchronized way. All the measurement, yes, it will be step by step priority for the first line, second line, but no need to wait for a big gap in between. So if it not work immediately, it doesn't work, we have to go shift to the second line immediately. And this is the art of the management of postpartum hemorrhage. So when the patient start, for example, bleeding somewhere, uterine balloon, tamponade is very important. This Bakri balloon, and this is recommended by WHO, American College of Obstetrics and Gynecology, the International Federation, I mean, the Vigo for Obstetrics and Gynecology Obstetrics, and by the Royal College. So all Western East, this guy, I mean, college and bodies recommend the balloon tamponade at least to transfer the patient for a better place, especially from the labor room or from the, even for the training as a midwife from, I mean, or from the primary centers or somewhere in the rural to the tertiary hospital. Uterine compression suture is very important, and this is in 1997, I mean, developed by Bielans, a very senior gynecologist, and it works properly in minimize of the blood pressure, I mean, the blood loss, and it range about 75% to 100 it works, and have very good success, and very important, and quickly act, and easy to be, I mean, to be gained as a skills for the trainees. Arteries ligations need special skills, need special, I mean, advanced centers work, and anyhow, sometimes involved by our colleague from the vasculars, and the internal iliac ligation mainly here, we needed to stop the circulation or to minimize the, the circulation for the pelvis. Main organ is uterine or uterus, but the major artery ligation, I mean the internal or anterior brush of the internal iliac, now by the proper ligation of the uterine artery in the side place, selective or non-selective ligations, it works, and it minimizes the bleeding to the level that we accepted by the I mean the institute, and it will save the woman. It's very easy, sometimes better than the advanced ligations.
Dr. Atif, 1 minute remaining.
Sorry, okay. Cell salvage, this is very important, but it needs a skill, I mean, a little bit expensive, and it needs, I mean, a special technique. And embolization as well, it works, but in well-occupied centers, because I doubt it works properly whenever the center is not well prepared, because it is need intervention radiology, and it has good outcome, especially in the secondary postpartum hemorrhage. Postpartum hysterectomy is very important because it should be timed hysterectomy, and no delay for that. It needs a second opinion, but it's really when it works by a good instrument, it will be a very neat surgery, and minimize the issue, especially in the case of morbid uterine placenta, when the cesarean hysterectomy had been decided before. We knew cesarean hysterectomy, very difficult decision, especially in the patient with, low parity or no parities. So this is very tough decisions, but sometimes life-saving. So this is why the time hysterectomy done at that really, on time by the senior persons, and it really minimized the need for more blood transfusion in a case of emergency, and if it planned surgery, like I mentioned critis conditions, it will be much better to be on time, and definitely will save the patient life. Management of postpartum anemia already managed by my colleague, by all the presenters. The issue is very important to give, a safe and better postpartum period without any problem, like at least it's here. And prevention also of postpartum anemia, especially patient had a bleeding, they can prevent their bleeding by proper supplement. I have to go for the challenging of patient blood management of obstetrics due to risk of postpartum hemorrhage. This is very important. We need to apply the systems. Implementation of patient blood management and obstetric provided opportunity to minimize bleeding and blood transfusion. However, large, well-designed clinical trials should be important in the field, and it is more challenging to implement this system in obstetric than the others, especially because at risk of bleeding. And in obstetric, there are several guidelines of management of postpartum hemorrhage, all agreed in the preventions, and comparing the guidelines for postpartum hemorrhage is a little bit different, but definitely the international group, they are important. Differences regarding blood transfusions. Challenging of patient blood management include identification women at risk and the patient who more likely for postpartum hemorrhage. Multidisciplinary approach is very important here, and RBC's transfusion, as I mentioned, is life-saving, and it should be applied to any procedures with a certain likelihood of excessive blood bleeding, including vaginal delivery and non-elective cesarean sections, and this is where the emergency one. And this system should be applied in obstetric and start during antenatal. This is a good time for the detection of the anemia and management of anemia. We do recommend anemia management and treatment, and we do recommend risk detection of that management and multidisciplinary team involvement as high quality for care of patient blood management. Patient blood management should be more thoroughly introduced in the clinical guidelines for all pregnant care units, especially at risk for postpartum hemorrhage and national and international obstetric societies. And really, by patient blood management, improvement of the skills, training of proper time hysterectomy, and introduce of the instrument, using the other case for management of prevention of postpartum hemorrhage and even antepartum hemorrhage. This will be by the good training programs, very important for the patient safe and identification of the anatomy and patient saving. Thank you very much.
Thank you very much, Dr. Atif, for the detailed presentation how to manage hemorrhage in antenatal postpartum hemorrhage. Now we'll go to our next speaker, Mr. Sadoun. He's from Wafer Pharma, and he works in Darat Al-Imarat Hospital in Abu Dhabi, medical director, consultant of IGANI. He will present to us iron deficiency anemia and women health in UAE private market experience. Thank you, Dr. Sadoun.
Thank you, and good evening, everyone. Thank you for this opportunity to meet everyone. Let me share my screen first. And you can see everything now on my screen, I believe. Let's open the presentation. Okay, so good evening, everyone. My name is Sadoun. I'm the Chief Medical Officer for UE Medical and Danat Al Imarat Hospital. Danat Al Imarat Hospital is the largest women and children private hospital located in Abu Dhabi. This is the hospital, and you can see that now it's 2 towers. Hopefully in December, January, we will complete the second tower with capacity of more than 200 beds. We deliver more than 5,000 deliveries. So we have a vast experience in women's health. The previous speakers addressed most of the issues, really. I'll try to cover different angle from the anemia and iron deficiency anemia in women's health. I'll address some of the problems facing women's health and what are the options available. I'll share some of our experience at the hospital. And then finally, we cannot finish without talking about the elephant in the room, COVID-19. So I would like to share with you some real cases. These are from my own practice, just to highlight some of the issues. The objective of these cases, not really to go deep into the clinical management of the cases, just to highlight that I'm a gynecological laparoscopic surgeon. So I stopped doing obstetrics for some time. I only do advanced laparoscopic surgery beside my work as the CMO. So case number 1 is a 38 years old woman, has 1 child, trying to conceive for the last 3 years. She's suffering from heavy menstrual bleeding. She's very tired with lack of energy, unable to tolerate oral iron. These are all real scenarios where the hemoglobin is 9.5. On examination, normal size uterus. This is the, you can see this is 2012 at the Midway Hospital where I used to work in the UK. And this is the saline hysterosonography with a 3D on the left. The yellow one is the 3D, and this one is with rendering, and this is the 3D. You can see this mass inside the uterine cavity, and that's after pushing. This is the saline here, and that's the hysteroscopy. So with all consultant colleagues here will say, yeah, the treatment is very obvious, resection of this fibroid, which we did to stop her bleeding. The second case is a 42 years old, has 6 children, also suffering from heavy and prolonged periods with the hemoglobin of 9, with the serum ferritin of 10. This is another image of hysterosonography, saline hysterosonography, with a 2D. And you can see this fibroid. We stopped doing hysteroscopies to diagnose fibroids or polyps. We use the less invasive technique, and we spare the hysteroscopy for a operative procedure. So you can tell that less than 50% of the fibroid is bulging through into the uterine cavity, and that's immediately can tell us this is type 2 fibroid. And again, going to the gynecology colleagues will say resection of this fibroid will not be helpful to improve menstrual loss for this woman. So we opted to give Mirena coil for her. And a third case, a very interesting one that I like always to share with my colleagues, because that took 3 hospitals to manage the woman with about 6 consultants. So she's a 52 years old, postmenopausal, came to my clinic with postmenopausal bleeding. She was known to have a small fibroid, then with the ultrasound scan was big. I'll show you the picture. Hemoglobin was 8. That is the picture, retroverted. This is a normal 2D scan. We do it in our clinics with the retroverted uterus and this fibroid with these changes in the posterior wall of the uterus. So there was a discussion about this could be leiomyosarcoma, center to UCLH, They said, yeah, this is leiomyosarcoma. Came back to our MDT. They said, not enough. We need to do MRI. They did an MRI with highly suspicious of leiomyosarcoma. In the UK, it's all centralized services. So I had to send her to Royal Marsden Hospital. She had a hysterectomy, but turned to be just cystic degeneration of the fibroid, benign one. And the last case is 28 years old woman, single, heavy menstrual bleeding, all the same with dysmenorrhea. She's on oral pills, hemoglobin of 9.2. That is the MRI scan. And you can see that this big fundal fibroid is affecting her. She had a myomectomy, laparoscopic myomectomy. So the message here is that they all suffer from the same problem. They are all fibroids. The first one, we had to do resection through hysteroscopy. Second one, we had to put a Mirena coil. The third one, we had to move with hysterectomy in a different hospital. And the last one is a laparoscopic myomectomy. I can give you more examples of the same problem, but having the different management. The message here is that it's a one disease, different symptoms, different management options, different approaches, because if we talk to different consultant or different colleague gynecologists, might give us different views. So they might choose a hysterectomy for the second, and or Mirena coil might choose a myomectomy for the last one, or but cannot be hysterectomy because she's still single. But what do they share is the same problem, which we, to be honest, as gynecologists, and I have to admit, as a surgeons, we usually have some arrogance that we ignore these simple things, which is the anemia and iron deficiency anemia. Remember, what bring the patient to the hospital is not the it's not the fibroid, sometimes the heavy menstrual bleeding, but what really bring them to the hospital is the effect of this disease, which is anemia and iron deficiency anemia. So not to forget that issue. We know by now that about 30% of women globally are suffering from anemia, and the majority of them are due to iron deficiency anemia. And that's I'm sure that was shown during this discussion. That's the distribution of women with anemia all over globally. Interestingly, in the region, comparing the progress of the disease, it's really disappointing to see that from 1990, looking at the United Arab Emirates, between 1990 and 2013, there was a minimal improvement in the management of anemia for both men and women. And this is not, in a region like this, very well advanced, talking about lots of technologies, artificial intelligence. We have a conference about artificial intelligence, but we are still struggling to manage a simple issue called iron deficiency anemia. And this is, as we all agreed, that the definition of anemia and iron deficiency anemia, it's different between pregnant and non-pregnant women, 12 to 11. Women in general, they require additional iron compared to men, and that's due to a menstrual blood loss. They usually require an additional 0.5 to 1 milligram iron per day due to the menstrual blood loss. And if we look at I'm sure this is again covered, but I will highlight this very quickly because I would like to link it to women's health. So reasons behind iron deficiency and iron deficiency anemia could be due to decrease in the iron absorption or increase in the demand, like in the pregnancy, infancy, and adolescence. Could be due to blood loss, which is, the most common one is the heavy menstrual bleeding, and the decreased iron intake. Think about these four main reasons, and you will probably see that women have at least 3, if not 4 of these reasons. So they menstruate, good number of them have heavy menstrual bleeding, they get pregnant, and my previous speaker highlighted nicely the potential problems during pregnancy and the bleeding and what could happen. But significant number of them are coming now with lots of bariatric surgeries. So I see women, the youngest girl had bariatric surgery was 12 years old. So just imagine that you have a bariatric surgery becoming a very common procedure that does affect the absorption. And also women are really becoming obsessed with their physique, and they like to stop eating at all because they would like to look like those celebrities. That's one of the side effects of the social media, because we really try to show ourselves in a different image, not reality. We are all living in a different bubble. So all these things affect the dynamics of the incidence or significance of the iron deficiency and iron deficiency anemia. So women go through this vicious cycle of heavy menstrual bleeding. They approach the pregnancy with anemia, and then they go to the postpartum period, and then they go into this vicious cycle. So not surprised that they end with a significant low iron. It is well known that about 20% of menstruating women are anemic, and about 67% of those with heavy menstrual bleeding have a hemoglobin of less than 12. And 1/4 of women hospitalized for gynecology condition associated with heavy menstrual bleeding. That is actually a little bit more in my hospital, because we are specialized in women's health, and our clinics are full of these cases, and you need to do something about them. Last week, I had to cancel 2 operations because they tend to be anemic, and I cannot take them to theaters to do laparoscopic myomectomy where the hemoglobin is 8 or 7. In addition, there is no point of doing blood transfusion because that was highlighted very well. It is not an option to manage or treat anemia. We'll come into this and discuss it briefly later on. So as you can see here, heavy menstrual bleeding are the leading cause for iron deficiency and iron deficiency anemia in women's health. And we all know by now that if we improve the hemoglobin and treat the anemia, the quality of life of those poor women will improve significantly. And you can see here the comparison between those with the mean quality of life and those with heavy menstrual bleeding and anemia, and those after treatment. Just a couple of slides about the iron deficiency and iron deficiency anemia in pregnancy and postpartum. The reason I'm showing these 2 slides because that will lead me to our data that we collected at Danat Al Imarat Hospital. Again, the level of hemoglobin in pregnancy to be considered as anemic is below 11. And we all know that throughout the pregnancy, the demand to iron increased significantly, with the peak is at the 3rd trimester and the postpartum period. It is estimated that about 41% of women are, pregnant women are anemic. We took a snapshot of our all pregnant women at the end of their pregnancy that's 2018, October 28 to October 2018. So it's took all 2018 to October time. We had 3,971 deliveries at that time. Currently, we deliver more than 5,000. We are approaching the 6,000. Hopefully, I'm sure Dr. Salima Wan is listening to me here. Dr. Salima, be sure that we will be at Corniche Hospital this year. I'm saying that in a good way. She's my friend. So at that time, when we looked at the total number of iron infusion, we considered them as anemic, and those we did not take those who are on oral iron. We did not take those who really we ignored or forget. There was 28% of them, so that's a significant number. Coming to the general management of anemia, we all know that the oral is the drug of choice, is it? Well, I have lots of my patients now. We are considering, not only the patient, the colleagues, considering the iron infusion is the ideal option. Oral can be an option for those who like to take the oral, but my experience, the compliance with the iron is really, really very low and good. The problem is if we give the iron supplement, we need to make sure we treat ourselves psychologically as physicians to say, oh, I've given her the treatment, but did we follow that? Did we find that whether she's taking it or not, whether she's tolerating it or not? The problem, you come into the end of the pregnancy and you see her hemoglobin is very low. That will add lots of challenges to your management. Blood transfusion, I'm not going to talk about this. We all agree that this is not treatment for anemia whatsoever. It's a replacement of the volume. It's an acute conditions when there is a bleeding to replace it, but it's not treatment for anemia. Now, with the iron infusion, we are still looking for the best option, which has no toxicity whatsoever, with no allergic reaction, no immunogenicity. It's not yet discovered, but we are nearly there. And the ferric carboxymaltose, I can admit that because we encourage that in our hospital and we pushed for this, and I'll show you some of the data to support my claims, is approaching that that area. One comment is when we started and replaced the previous infusion with the ferric carboxymaltose, we had some issues and panic at the beginning, though allergic reaction, this and that, and tend to be is really is about learning how to prepare and how to manage those patients. So far in the last year, I did not hear any single patients with allergic reaction. I say this with confidence because I put the regulations that any allergic reaction must raise an incident form. So for the last year, we did not have a single case. Now coming to the two concepts, two areas that I would like to really highlight. And now I'm moving towards becoming not only a physician, but also as a management and my leadership role. The concept of the price, cost, and value, it's really very important. And I always show the next 2 or 3 slides for people to understand that getting something that is cheap does not mean it will not cost you a lot, and does not mean that the value is high. Sometimes getting a little bit more costly product can be cheap at the end because it can give you lots of value for money. Apply this to your shopping attitude. People are divided into 2 main groups in general. One group is like to buy as many products as they like. I don't do this because psychologically I hate seeing many shoes in my cabinet, and contra, that's completely different from my wife who would like to see lots of things. But are you really going to use them all? Are they going to stay with you for a long time? Will they give you the comfort that you are asking for? That's
Sorry,
a big
Dr.
question.
Sadun.
Yeah, sorry.
1 minute left, please.
Oops.
If you don't
Okay.
mind.
Let's
Thank you.
go to the next. The next slide is you need to make sure when you decide about any product, it's to get it as effective as you can and as cost effective as you can. This is the data from Danatil Imarat. This is the sucrose and coming between 2017 to 2020, and this is ferric carboxymaltose. I have to say for 2020 is data up till August. We are still collecting the rest of it, and you can see the number of cases are going up. What's interesting here, I want you to look into the hours per patient. If you talk about iron sucrose, we need sometimes 3 hours per patient to complete. and the number of, while in the ferric carboxymaltose is significantly lower than that, is nearly 30 minutes, with the number of visits up to 5 times or 6 times here, while here the maximum is 2 times. So we took, hypothetically, if we change the whole profile of our patients for 2018 from 2 ferric carboxymaltose, we would save about 247 working days, which is equal to 41 working week, which you can appoint a full physician for the full time for a year. Now, what else? Life will never be the same after COVID-19. We are now interacting virtually. That was unheard of, that we go through the Zoom to meet each other. We stopped some of our elective procedures. We introduced the telemedicine heavily. We moved into home consultations. We are worried to bring the patient to the hospital. They are worried about themselves. In my hospital, I don't allow any visitors to come with the patient. So we need to be efficient. So I just want to pass one question to you. Would you like to bring your patient to the hospital 5, 6 times, putting an IV line, invasive procedure to give an infusion, or once for during that treatment? That's a question. I will leave it to your judgment. So the take-home message is that we need to address this issue, but we need to look into what available options, and we need to choose the right one, which is the good one for your patients, the efficient process, including cost efficiency, not looking at the cost only. With this, I would like to thank you all. Happy to take any questions. Thank you.
Thank you very much, Dr. Zahdoun, for giving us the experience in private. And we would like to start the discussion part, or the questions. I think it was muted. Thank you, Dr. Zahdoun, for the presentation. And because of the shortage of time, please, can we proceed for the discussion now? And the first question is that Dr. Salima Wani, can you please tell us any equation of calculating the iron carboxymaltose, and when to repeat the hemoglobin after that? And do we need to give steroid with it or not?
Oh, very interesting question. The first part, let me take. Don't use complex calculations to calculate how much you need to give. Remember, less than 9, more than 9. Remember the weight of the patient, less than 50, more than 50. If she's less than 9 grams hemoglobin, less than 50 kilos, give her 1,000. If she's more than, she has more than 9 grams and she's 50 kilos, you have to give her, she's less than 9 grams, but weighs more than 50 kilos, you have to give 2 grams. Very, very simple calculations. And when you can give 2 grams, if the hemoglobin is less than 9, you have to give them 2 doses and 1 week apart. You need to make sure you give one this week and another 1 week later. And regarding the do you give steroids, the answer is big, big, big no. You don't need any steroids. You do see some patients when you inject, they may complain of irritation or even erythema around the site of injection. Don't get worried about it. It's not, you're worried about anaphylaxis. So you don't need any steroids. The third question, when you should repeat hemoglobin, your 2 weeks will give you the answer. Is the patient responding or not? If you want to see, follow this patient, because if you don't, please check ferritin. The ferritin will be 800 even to 1,000. Don't get worried about it because it is present in the reticular endothelial cells. So it doesn't get stored, it doesn't get released immediately. So you may get even a rise up to 4 weeks, even 6 weeks. So if you ask me, when should I check it? Usually between 2 to 4 weeks.
Thank you very much. Dr. Hisham, a question to you, please. When do you think it is required to check iron level and iron binding capacity for patients with iron deficiency anemia? Can you unmute yourself?
I think he's not there.
Maybe he's not there. Okay. Okay. Dr. Salima Wani.
Yes, I can answer.
Can you answer?
Yes, definitely so. I think you don't do iron binding capacity as a usual test. If you do your CBC and you look your hemoglobin, you look at the MCV and you look at the ferritin levels, most of the times the answer is there. But if you have a very severe anemia and you are not sure what the anemia is, please go for the transferrin because you want to differentiate between overload and the transferrin levels. This is the only indication why possibly you will do it.
Okay. One more question, please. It seems that you are ready to ask you questions more. Can we give IV iron with blood transfusion?
Oh, and not at the same time, please, not at the same time. But if you give blood transfusion and you want to give next day ferric carboxymaltose, iron IV infusion, please go ahead. There's no problem.
So during admission, at least, during admission, suppose she's admitted for 3-4 days. Can we do that?
Yes, exactly. You can. You can give. Don't give together. The only thing is don't give together iron and blood, but otherwise you can separate, give on 2 consecutive days. It's fine. Absolutely fine.
For allergic reaction issue or for what?
Okay, basically allergic reactions, because if a patient develops allergic reaction, you don't know it's blood related or it's iron related. Yes, especially anaphylaxis with.
Okay,
Dr. Tagreed, can I add points here? I think
Please.
it depends on the diagnosis itself and the indication for the blood transfusions and the prioritization for that. As far as the blood transfusions being prioritized over the iron injections, it seems as the condition is more serious or very mandatory. Then we can, for the rest of the supplementation, we can add this iron injection for the rest of the period of the coming time as a prevention or more support.
Suppose the patient is already anemic and she delivered and she developed postpartum hemorrhage, and now we want to give her transfusion. Can we give blood transfusion followed by IV iron?
Yes, but not at the same time. Let us to settle the condition. If it is especially is an
Okay.
active or acute phase, then we go for the non-active acute phase after the blood transfusion.
Yeah, this is
Okay.
exactly what I said in my talk. Actually, we can give the blood transfusion just to stabilize the patient. So give her 1 or 2 units, okay? But then the next morning, give her the pharyngect.
Yes.
I just want to add, I think we have gone away from 2 units because if you previously remember all the time, it was, if you want to give blood transfusion, to give 2 units. We have totally gone out of that. We give only 1. And we have a team in the hospital. If things can be done with 1, why to go for 2? So what we do, if the patient is bleeding or patient is having tachycardia, symptomatic, give 1 unit and stop there. Because most of the times you can support them with the parenteral iron. So I think, again, we need to go where things can be done with 1, don't go for 2.
Dr. Hisham, can we give IV iron in the first trimester?
No.
If the patient is tolerating that?
If you ask me myself, yes, I have the confidence to give IV iron in the first trimester. Although, if you ask the company for itself, for example, they say, well, it is off-label because according to the current recommendations, it still should not be given in the first trimester. But I have used it in certain patients, and really I didn't see any problem with that, especially patients who are severely anemic.
Okay, Dr. Hisham, can we give the first dose of pharyngect in primary healthcare settings, or the first dose of pharyngect or IV iron should be given in a hospital setting?
It depends on the setup in your primary care unit or dispensary. If you have a setup for receiving emergency cases or dealing with anaphylaxis, yes, I mean, you can give it in a primary setup, no problem, considering that the patient has been worked up for the diagnosis, proper diagnosis of iron deficiency anemia.
Dr. Salima, up to what gestational age you can give just IV iron?
I will say 1 day before even.
Okay.
1 day before delivery even. Okay, because the question is, if the patient is stable, she's not actively bleeding, you are not going to treat her with blood transfusion. You are looking for improvement in her condition, which can take about a week. I have seen even patients where we have 1 day prior to elective cesarean section, we have given them at 8 grams hemoglobin or 7 grams ferric, ferric carboxymaltose, operated on the next day, didn't need any blood transfusion, and she got away without transfusion. So again, it is not a matter of that how many days. It's not a time period limit. It's any time, whenever you have an opportunity, you can give them. The only worry is if a patient is going to have a massive hemorrhage during surgery, that's the time while I will be worried. That's the time while I'll keep my blood ready. Like if I'm doing placenta brevia accreta, definitely I will keep the blood ready for that particular patient. And I can give the iron before. I have no problems in that.
From your experience as OB/GYN doctor, did you notice that IV iron carboxymaltose reduced the incidence of postpartum hemorrhage, even if it is given late, immediately before surgery?
Oh yes, absolutely. Because anemia of its own, it's not it's not giving any IV iron, which is reducing the risk of PPH. The answer is no. But if you can improve the hemoglobin, you reduce the risk of PPH. It's other way around.
Okay. Dr. Hisham, when we can see the response of oral iron therapy on anemic pregnant lady of 1 gram increment?
Oral iron therapy?
Yes.
Okay.
The
Well,
question.
okay. Usually we start with 60 milligram of elemental iron, and you should give it for a whole month. Only after 1 month, then you reassess the hemoglobin, the reticulocyte count, and the serum ferritin. If there is an improvement of 0.5 gram per deciliter increase in the hemoglobin, then you continue for 2 more months. If there is increase by 2 grams, then you continue orally, no problem. But in any of these situations, if these limits has not been really achieved, then you switch to intravenous iron.
Thank you. Dr. Salimawani, any precaution you take while giving the IV iron? And do you advise the patient anything before you start the IV iron?
Okay. We give IV iron in an outpatient setting in our hospital in a day assessment unit. What we do when the patient arrives, we take a history, we check the vitals, we check the blood pressure, and we start the infusion. We don't prepare the infusion, it's prepared in the pharmacy. It comes and we start. We don't leave the patients immediately after finishing. We observe them for another half an hour and to make sure she's vitally stable and do. We don't tell any special precautions, but yes, if you are sitting in a hospital, definitely your emergency kit is always ready. You are always ready for anaphylaxis. So far we have used, you can see the amount of doses we have used, almost 4,000 doses in a year. We didn't see any anaphylaxis. We do see side effects, but we didn't see anaphylaxis. So we are having side effects, like some patients, they do feel dizzy, they do have rash or local reactions on the arms, but we did see anaphylaxis. We are worried about anaphylaxis, not on the minor side effects.
Dr. Hisham.
I haven't seen any anaphylaxis, honestly, from pharyngitis.
Well. No, nothing.
Dr. Hisham, if the patient has iron deficiency anemia and thalassemia coexist, won't this IV iron be harmful to them? The question.
Fair enough. Actually, you have to identify whether this thalassemia is a trait or a disease, all right? If it's a trait, just treat this woman like any other normal, healthy person. Forget about the thalassemia as long as it is trait. If she is a thalassemia patient who's really requiring sometimes blood transfusion, etc., well, this is a different story. And in this case, you have to look not just for ferritin, but you have to look for other parameters. This is what we call the secondary investigations that really have to come in picture. Maybe the serum transferrin percentage should be less than 1 to consider any hemoglobin to be given. If it is above, you shouldn't give it because just to avoid the hemosiderosis, etc. But definitely there a picture where you have to include also the hematologist with you, because these are patients who just not really like an ordinary patients. They sometimes need hospitalization, etc.
So thalassemia major, they have high ferritin and they don't need iron, but the one with thalassemia trait, sickle cell trait, any hemoglobinopathy trait, treat them like iron deficiency anemia alone, right?
Yep.
Okay. Dr. Salima Wani, if you have, thank you and very nice presentation. If you have a patient in second trimester, like 14 to 15 weeks pregnant, and her hemoglobin is 10, but her ferritin is below 3, what you will favor, oral or IV?
I always favor iron oral first. If she
Okay.
cannot tolerate, or she's non-compliant, or she has side effects, or she has bariatric surgery, these are my red flags. I will go for an, or she has a celiac disease, gluten, sensitivity, or inflammatory bowel disease. I'll go IV. Otherwise, start my first preference oral.
Dr. Atif,
Yes.
I would like to know after how many hours should I do hemoglobin check after blood transfusion?
This is very tricky question as well, not only by arterial blood gases or by complete CBC. I think maybe within less than 12 hours, 24 hours, it'd be of great value. This is in a case, an acute phase or active phase, when we give the blood until the arrival of the blood, we give any crystalloid, it will mask the anemia or unmask the anemia. So it depends on how much you or how which method you follow to resuscitate your patient. If it's pure active blood transfusion from the beginning, most probably within 12 to 24 hours, this give you a good result. Okay, a real CBC, not arterial blood gases. And if you use a lot of fluid, better to wait for relief that hemodilution and let the organ take their blood supply properly, the kidneys, the outcome and washing of the kidney and so on. So minimize the risk of
charger.
minimize the risk of these other comorbidities, then you can test it within 24 hours.
Agreed. If I can add to it, we in our
Yes,
hospital
please.
have a policy that if a patient had a massive transfusion and has a massive naturally blood loss, we follow them within 6 hours. We repeat the hemoglobin to see how the patient's values are, because we don't want to miss an active small bleeds inside. But yes, as Dr. Atif put it, you do the 6 hours later. If she's stable, then we do it next day. We don't do any further unless the patient has any symptom or she becomes tachycardic or anything, then we repeat it on the next day.
One more point, Dr. Salima here. Thank you for your comment. As far as the patient is actively bleeding, as you mentioned, internal hemorrhage, I think the assessment of hemoglobin itself is not any good. Hematocrit is maybe better here at all the schools. And in addition to that, the other things that may be apparently good hemoglobin, but the other factor like fibrogen is very low. And this is may give you the viscous cycles of the, morbidity, if not mortality. So better to support the patient and to come from the acute phase on lung, not acute organ injuries, maybe the kidney, maybe the lung, and then go for the better stabilization, and then we can give the proper assessment for the patient as a whole, not only giving the blood as a parameters, the general condition as well.
I think
Okay.
I will add one more thing in massive hemorrhage. We don't use any fresh frozen plasmas at all. We are almost very down, zero. What we use a lot of fibrinogen, and we have a fibrinogen availability. We use fibrinogen as our in massive transfusion protocol. Our main thing is not to use much of fresh frozen plasma. Our first priority is to go for fibrinogen, because we take a cutoff of fibrinogen less than 3 for us is a disaster. In an actively bleeding patient, we go ahead and give them the fibrinogen. It's very expensive, but it's worth.
Another comment, Dr. Salima here. This is the best tertiary setup for the management of postpartum hemorrhage. Sometimes there is a center in between. We accept whatever to save the patient and to bring it to safety.
Absolutely. We used to use about 4 years ago only fresh frozen plasma, frozen.
Exactly.
Now we have moved towards out. Yes.
So,
yeah.
Thank you, Dr. Taghrib.
Dr. Atif, any role of activated factor 7 to minimize the bleeding?
I think still this is need a proper evidence and randomized control trial, because there is no selectivity for this factor to be lost by itself without the others.
Okay, Dr. Hisham, should we postpone hemoglobin electrophoresis in a patient who has recent blood transfusion or can we do it and it might tell us some information?
Well, you have to postpone it for at least a matter of like 3, 4 days in order not to have a mixed up from antigens received from the blood from the donors, and that's why the level of different adult HPs and others should wait against the contamination of the sample.
Okay. Um, what about the genetic involvement in iron deficiency anemia? From your studies, Dr. Salima Wani and Dr. Hisham, about genetic predisposition in the area, what did you notice? What's your experience about genetic predisposition to iron deficiency anemia?
As far as I know, there is no gene concerned here that really influence the loss of iron from the body, unless you're talking about inflammatory conditions. Here, we have something like those who are affecting the interleukin-6 productions, and sometimes the take up of the iron by the bone marrow stores. So very rare conditions that may play here as a predisposing factor in terms of iron deficiency through these inflammatory conditions.
I think I would
Dr.
say
Yeah.
the iron deficiency as a genetic background is not important. We have hemoglobin, other than hemoglobinopathy.
Can you come closer to the mic, Dr. Salima?
I think main thing in there's no genetic predisposition for anemia except if you have hemoglobinopathy. Other than hemoglobinopathies, there is no predisposition as a gene.
Okay, Dr. Sadoun, is it okay to give repetitive doses of Pharinject during the year to the same patient?
Technically, yes, but the question is why. I consider that if we keep bringing this patient to give iron, it's a failure of the gynecologist. We need to treat the source. Iron is to control the symptoms, improve the symptoms, and then until you have the time to complete the treatment. So technically, yes.
Okay, Dr. Sadoun, for patient with anemia and very low ferritin, and you've treated her as now she is normal hemoglobin, delivered, but not yet the stores were filled. For how long you will give postpartum iron if she's not tolerating oral?
Well,
IV
it is well
iron.
known. Yeah, it is well known now that there is a very lots of similarities between iron deficiency and iron deficiency anemia. You have to treat the iron deficiency as well because patients have also symptoms, but it's not as bad as the anemia itself. And for how long? It's until you have the good storage of iron. If she's not tolerating the oral, the question is, you need to also to ask yourself why this woman is having this low iron. Is it because of the blood loss? So you need to go back into manage the main reason.
Dr.
So,
Salima Wani. Oh, yes.
To me,
Yes,
I
please, go.
manage both the same seriousness, same not only the hemoglobin, but I treat the iron deficiency.
Thank you, Dr. Salima. If she comes to you in the pre-pregnancy state, which is rare in our community or very rare, if she comes to you in the pre-pregnancy period and she's planning pregnancy and you found she is anemic, will you postpone pregnancy till you manage to raise hemoglobin to normal level before getting pregnant, or you allow her to get pregnant?
If she's not in rush, best is to optimize her hemoglobin even before she embarks pregnancy. But if she's not going to wait, which are mostly the unplanned pregnancy, it's unusual a patient coming for hemoglobin improvement before pregnancy. But if she comes, I'll prefer if she gives me a 6 weeks at least or 8 weeks to see what her hemoglobin is, to have it prevention much before the pregnancy is much better than treating her during pregnancy when they cannot most of the times may not tolerate or may get more constipation or side effects of GI side effects. The best things to do before.
Dr. Hisham, do you recommend doing hemoglobin in the postpartum visit to check safety or improvement in hemoglobin level for anemic patients, or you don't want it as routine?
I'd like to comment on the previous question regarding patients having coming before pregnancy. Yes, I will just give her one shot of pharyngect and tell her get pregnant, because within 4 weeks, I'm sure we'll optimize her hemoglobin and ferritin. That will be maintained for 6 months or so with pregnancy. If the patient is mine, usually I do postpartum hemoglobin checkup before for that purpose. If she comes in and she is anemic and she put on some kind of treatment, yes, I will repeat it in the 6 weeks visit. If it was normal, no, I will not do a 6 weeks.
Thank you very much, everybody. I'm done with the questions on the screen. And I would like to thank you again and again for the excellent presentations. We really enjoyed your presentation and the discussion. Thank you, audience. Thank you, our sponsors, V-Pharma. So thanks a lot again and again.
Thank you very much. Thank you.
Thanks a lot.
Thank you very much.
Thank you very much. Thank you.
The CME will be available in 10 days' time. Please fill out the evaluation form and answer the post-webinar quiz that will be sent to your registered email ID to obtain CME credits. The webinar will be available on demand on the YouTube channel, youtubechannel.com. And thank you for attending the webinar of today. Please join us for the next webinar. Thanks a lot. Goodbye and good night.